everyone to our annual Know All Your Treatment Options event. You know, many of you know May is National Brain Tumor Awareness Month. So there's two things that we try to do during the month of May, and one of them is to bring you some disease education programming, and we put that under this event, which is called Know All Your Treatment Options. And we want to thank our presenting sponsors for our Know All Your Treatment Options event, which is GammaTile. Thank you, GammaTile, as well as KAYTO. Thank you. You know, we are a 501c3 nonprofit, so we do rely on dollars in to help support our patient disease education programming as well as our services. So again, it's really, really important, and we truly acknowledge the excellent support that GammaTile and KAYTO has provided to the End Brain Cancer Initiative for today's program. Thank you. I wanted to provide my contact information in case any of you have additional questions or the End Brain Cancer Initiative can help you in any way. That is my contact information. That gets directly to me, so please utilize if you would like. And not only do we have support from GammaTile and KAYTO for this program and today's inspirational National Hope Award initiative, we also have support from others. So I wanted to acknowledge that today. Servier, thank you very much for your support for our patient disease education. XCures, thank you so much. Fred Hutch Cancer Center, ZAP Surgical, Novacure, Westchester Medical Center, thank you for helping us support in kind our Know All Your Treatment Options programming today. Also, it's very important for us to recognize Novacure. Novacure has sponsored our National Hope Award, a patient disease education awareness and outreach initiative, I want to say for 10 years. and thank you so much, Novacure. We really couldn't do this without you. Really appreciate your support. The purpose of our National Hope Award is to learn from patients and their caregivers, to shine a light on them, and to learn more about how they are inspiring others, how they live their life, and how they are treating their brain tumor or their brain cancer. Thank you, Novacure. It's really important and exciting that I share with you that tomorrow, May 18th, is actually the anniversary. It is the 22nd anniversary of the End Brain Cancer Initiative. And so literally 22 years ago, tomorrow, my late husband, Chris Elliott, and I created what we all used to know as the Chris Elliott Fund for glioblastoma brain cancer research. You all know this organization as the End Brain Cancer Initiative today. So I just wanted to acknowledge our 22 years, which I find, wow, really surprising. But I also have to tell you, I'm extremely proud of the work that we have done in this last 22 years for the patient community, the patient brain tumor community. Thank you so much. I'm also proud to announce that tomorrow, May 18th, the End Brain Cancer Initiative worked directly with Governor Inslee from the state of Washington to proclaim May 18th as Washington State Brain Tumor Awareness Day. That's just a small little piece of advocacy that's going on behind the scenes. Thank you so much, Governor Inslee. As I mentioned, we are a 501c3. Anybody can make a donation to the End Brain Cancer Initiative to support our work, our services, which all are free, by the way, to patients, caregivers, and their family members. We make it really easy. You can text EBCI 244321. You can scan the QR code. And of course, you can always make a donation online at our website, www.endbraincancer.org. Thank you. Really quickly, I wanted to let everyone know that the End Brain Cancer Initiative is actually seeking a patient with recurrent GBM and their caregiver. We're looking for 2 pairs to work with us and finish a study that we started. And we only need, truthfully, 1 more patient and caregiver pair that we can pre-qualify for the study This is an informational study only. There's no treatment involved. And so if you are interested, I ask that you contact right in front of your screen, Shreya Prakash, directly at In Brain Cancer Initiative. Feel free to note her email address and her phone number, and we'll pre-qualify you for this study. And we'd love to finish it. The purpose of the study is really to learn more from the patient voice who has recurrent GBM, from the patient perspective, as well as the caregiver perspective. So thank you. So the inspirational part of today is our 2024 National Hope Award, which is a patient disease education awareness and outreach campaign and initiative. And so every year we go out to the public and we seek nominations. We ask for people to nominate patients that are brain cancer patients in their world that they find inspiring. And we ask them to share a little bit about them, excuse me. And the nominations come in, we review them as a team, and we pick our top 3. And then we decide that we will interview them more and again. And then we will also create some inspirational videos. So last year, we had the pleasure of honoring Jen Ortiz. And I don't know, Jen, you were going to join us. I know you're going to be a little bit late, but if you're there, hello. Jen received our Hope Award last year, and you see her right there on your screen, and her family as well. And she is, she's a, brain cancer survivor and recurrent GBM as well. She's been doing a lot of advocacy work with the In Brain Cancer Initiative, as well as other groups. And she's been very active about creating a lot of awareness about this disease. Thank you, Jen. Thank you so much. I look forward to seeing you next time I'm in your neck of the woods in the US. See you soon. Thank you so much, Jen. And now I would like to thank 2 of my team members, Susan Kellner and Ted Lazarski, who created the videos that you're going to be seeing in just a moment. So I wanted to thank them. And it's a lot of work, and sometimes we forget to say thank you. So I really wanted to take a moment to say thank you. All right. So one of our top 3 National Hope Award nominees is Patty O'Donnell. And he's actually joining us today with his mom, which is so great. Hi. Oh, you're waving. Good. I love it. I love it. I see you. Oh, I think we're going to see Patty's video right now.
I was in the summer heading into my junior year of college, and was preparing to head into the next hockey season. And after one of my practices at home in San Diego, well, on the ice specifically, when I was practicing, I experienced some numbness on my left side. I made it home. I was apparently incoherently mumbling to myself while standing in the shower, fully clothed, and he took me out of the shower and put me on my bed, and that's when I began to have a seizure. I think I was in a coma for a day or 2. I had an appointment with the neurosurgeon, and when I went into the meeting with my parents, I guess my dad had heard of what glioblastoma was, so he kind of picked up right away what was going on. I've noticed it's people are like naturally, gravitating towards me and supporting me, and it's really awesome. The hockey community, especially in San Diego, is growing larger by the day, and we're pretty tight knit, and so we all support each other, and it's really special. The hockey team had a gray for glioblastoma night, and we had awesome jerseys, and I got to drop the puck. We're auctioning off the jerseys at the end of the night, and donating the proceeds. And so that was really awesome to see so much support, and it's definitely been a big part of it for me. And I think having a very close, tight knit group of family and friends definitely helped me through that. as I try to really keep a positive attitude through all this. Like I said, like your mental state is incredibly important, and I think that's a big deal, having, being able to control your mental battleground, and stay hopeful. I mean, I think hope is really what drives us all. Get up in the morning and create a better future for ourselves, and I think hope is incredibly important. And I think about this often, that there's going to be ups and downs, and you just have to stay hopeful to the end of the goal.
Thank you, Patrick. Hey, Patrick. So your mom actually nominated you for this year's Hope Award, and she wrote many amazing things about you, but some of the things, if I could share, is she says Patty is undaunted and believes he will beat this disease. He wondered early on what he did to get this disease and why. But he realized that that was not useful. And so he focused on healing, whatever it took to beat and heal and develop a winner mentality. He tells us he had to shift his entire focus to getting better and beating this thing, or nothing else mattered. He adopted a mindset that it was going to be tough, but he would beat this cancer driven by a desire to return to a life he loved as a student with his friends and his teammates. I love that. I think you're incredibly inspiring, Patrick.
Thank you so much.
Yeah, thank you so much for sharing your story with us. And I look forward to talking to you a little bit more in the days to come to learn even more about your story, if I may.
Absolutely.
Thank you, Patrick. We are going to actually, Jessica is really got an amazing story. Jessica, I think you're a 34-year survivor of GBM. Is that correct? I think so. So Jessica was diagnosed with glioblastoma as a child and has survived for over 30 years. I think it's 34. She has displayed great strength and faith in battling this disease. Her story is truly exceptional and inspiring. Let's see. Jessica's friend nominated her. And she was actually diagnosed back in 1991. Her tumor covered half of the left hemisphere of her brain when she was only 8 years old. And she was already dealing with another disability on her left hand, which was a birth defect. We call her the miracle child. She has made history by simply being we believe to be the oldest living patient with GBM. Jess tells her testimony to everyone, whether they be a kid or an adult. She is an inspiration. Next, ladies and gentlemen, let's see Jessica's video.
The date of my diagnosis was in June of 1991. I was 8 years old. I'm 41 years old now. I had glioblastoma multiforme, stage 4. My tumor covered half of the left hemisphere of my brain. I got the best neurosurgeon in the world named Dr. Peng. Dr. Peng had a meeting with my family, and he asked them if they believe in God, and all of them said yes. And he looked at my mom and said, I suggest that you all start praying. My surgery was June 17th of 91. It lasted 8 hours. I had to have 2.5 years of chemotherapy. I had to have radiation. I am the first kid to grow into adulthood and the first adult in the world to survive over 5 years. I am considered cured. I have seen tons of neurosurgeons, but the last neurosurgeon that I saw said, why are you here? When I got to my 30th year, you know, I woke up and I'm like, oh my God, I'm definitely a miracle child. And I was happy for all the times that I got to go out to speak in public and to, you know, tell my testimony and to, you know, tell anybody that I had met, keep hope up, keep courage alive, God can save anybody. Look how far I've come.
Jessica, are you joining us today? I hope she is. She really, truly is really inspirational. We have one more patient that we'd like to have you meet today. We call her TJ. TJ is, it is said that TJ is the most courageous woman I know. While fighting a battle to win brain cancer, she has remained positive and strong while embracing her family and friends with love and gratitude. Although she does have some fear, she never shows it. She continues to put her children and her family first in all that she does, even with the time-consuming medical visits and medical care that she receives. She loves her life to the fullest and prioritizes the things that really matter to her. She continues to be an inspiration in how she views life, lives life, and and how she places love onto others. TJ, are you joining us today? So let's take a peek at TJ's inspirational video.
January 2nd, I recall vividly. It was a normal morning. I woke up just going about my normal morning business. And TJ usually wakes up the same time I do and gets going. And that morning she wouldn't wake up. And so I kept kind of just nudging her, thinking everything was fine. We didn't know what was going on, but she was unresponsive. So we went to Emory and met with a neurosurgeon there. And his immediate response was, let's do surgery. I can remove those. Like, no questions asked. Yeah. She had surgery. It was a tremendous success. The guy, Dr. Olson's his name, he did a tremendous job. And we spent a couple of days in ICU, and she just bounced back. And then began the treatment regimen. But really, ever since then, there's certain issues you deal with, of course. But we've been just going through the treatment plan. And
when this happened, it kind of throws you into like the whole having faith, and I've been I got diagnosed and everybody's just giving me like devotional books and all this stuff. So that's really helped me kind of see things differently and stay positive and always have something to kind of look forward to. And since then, like, I got to see both my kids graduate from high school. So now they're both in college, and just like going to his college and her college and going to games and parents' weekends and just trying to have something to look forward to and stay. I can't lay in bed and feel sorry for myself, and I don't want anybody feeling sorry for me. So I just am like, I'm going to just keep going as much as I can. And if this didn't happen, I feel like I live differently now. I'm so thankful. Every day I wake up, I am so thankful. It's just changed my vision on a lot of things, and I don't take anything for granted. And there's just lots of hope I have.
I'll just say that she amazes me how tough she is.
Thank you, TJ. And Matt, you have a very special wife there. TJ, you are very inspiring. I want to thank you for sharing some of your story with us today. So our group got together and we decided, although every single nomination that came in is truly inspiring, And we want to thank everyone who submitted a nomination for our 2024 National Hope Award. But we have decided that our recipient of our 2024 National Hope Award is, it is Patrick O'Donnell. Patrick, are you there? Can you hear us?
Yes, absolutely.
Hi.
Hi.
Well, it's an honor to be able to, the End Brain Cancer Initiative, to be able to give you our 2024 National Hope Award, which I don't know if you can see this, but it looks like this. It's a crystal cube. And it has your name on it. It has, of course, our End Brain Cancer logo. It has Novocure's logo on it. Novocure is our presenting sponsor of this fantastic initiative, and it has the year on it. So we will get this to you, Patrick. Is there anything you would like to share?
I'd just like to say thank you so much. It's an honor to be recognized for all my hard work.
Well, you were very inspiring, my friend. I've actually had the pleasure of meeting Patty in person. And if we all get really lucky, I know where you live. And I'm in that part of the country often. So I might even be able to deliver this in person, which would be so fantastic. And it would be such an honor to do so. So thank you. Thank you for your inspiration. Okay. And, you know, it's people like you and all the others that we met today that help others also, right, thrive and help them get through their brain tumor diagnosis. So thank you so much for being such a great role model and inspiration for so many people. Thank you, Patty.
Yeah, thank you.
Yeah.
I'd like to thank all the other nominees as well. You know, it's people like that that make me, believe and keep me going.
Yeah, we hear you. Thank you. All right, my friend, have a great day, okay?
You too as well. Yeah.
All right, and thank you again, Novocure. This is such a pleasure to be able to do this programming every year. Thank you very much. Okay, I think with that, we will move into our patient disease education programming. And our very, very first presenter today is Dr. Simon Hanft. And he is a board-certified neurosurgeon specializing in the care of brain tumors and tumors involving the spinal cord. He is the section chief of neurosurgical oncology for the Westchester Medical Center Health Network. He grew up on Long Island and received his undergraduate degree from Yale before obtaining his master's at the University of Cambridge in England. He attended medical school at Stanford, during which time he received a prestigious Howard Hughes Fellowship to study neurostem cell networks. He went on to complete neurosurgery residency at Columbia Medical Center and the Neurological Institute of New York, followed by an additional year dedicated to brain tumor surgery as a surgical neuro-oncology fellow at the University of Miami. He then joined the faculty at Rutgers Robert Wood Johnson Medical School and developed the most active brain tumor practice in New Jersey. He has contributed to multiple peer-reviewed publications, including operative videos demonstrating surgical technique. He is an author of 5 book chapters on brain tumors, 2 book chapters on spine tumors, and the Medscape entry on brain surgery entitled Craniotomy. He is also the lead editor on a published textbook entitled Tumors of the Spinal Canal. He has twice been recognized as a top doctor for New Jersey Monthly Magazine, and he received a medical advisory award by Voices Against Brain Cancer, one of the leading national charities for patients with brain tumors. He has over 500 verified patient reviews on health grades, which makes him the most highly reviewed neurosurgeon in New York and in the top 1% of doctors nationally. Wow. Okay. We can't wait to hear from you, Dr. Hanft. Are you there?
Not only am I here, but now that you rattled off all these credentials, I feel bad we didn't invite my Jewish mother to join this webinar here.
So do I.
Yeah.
Next time. How are you?
Thank you. Thank you so much for that.
Thank you for
I'm gonna-
joining us, sir.
Yes, I'm gonna share my screen. I think that's
Okay.
probably gonna be the best.
That sounds fab.
So first of all, again, thanks for all of that. It's greatly appreciated. I want this audience to know that this is really a unique opportunity for me, and I'm thrilled to have this platform because, as you might imagine, the overwhelming majority of the time we're giving any type of talk about what we do, it's often to people in our field or people who have some relationship to the field, and it's not often that we get an audience with patients, survivors, really the people that we actually are attempting to treat and help. So this is a very unique circumstance, and I'm greatly appreciative of the opportunity. What I'm here to talk about today is a technology that's become quite near and dear to me, and I've become really a devout user, if you will, of it. It's called GammaTile. And as I'll get into in the coming slides, it is a type of brachytherapy, which is it sounds very novel, but is a long-standing technology whereby radiation is implanted in the surgical bed after tumor removal. Interestingly, it's something that we see in other fields outside of brain surgery. So you may have heard of its application in prostate surgery, for example. And there is quite a history and prologue to GammaTile in terms of use in the brain, but this, in my mind, represents a clear technological step and advance, and that's why I am quite enthusiastic about it and eager to share some of the details with you today. We don't need to go over this again. So just to give you guys a general overview of what we're dealing with. Glioblastoma, though somewhat rare, we're still talking about over 15,000 new cases a year. And when you in the United States, and then when you add the number of metastatic tumors to the brain, you're getting close to 250,000 new patients, new diagnoses annually. And as we're starting to see longer term survivors in the cancer world, that gives more of an opportunity for cancer to spread to the brain. And so we're seeing an increased incidence of metastatic involvement in the brain, which is an unintended, but in a way, a good consequence of the fact that we are seeing longer term survivors, primarily due to advances in immunotherapy. One of the fundamental challenges with malignant tumors in the brain is what you see here, which is that there is a high rate of recurrence. That's what truly makes these malignant entities, that it's not so much that they cannot be removed completely or what have you. It's just that the likelihood of regrowth is extraordinarily high for various reasons that I don't get into in this particular talk, but there are a host of reasons as to why these tumors come back. And so one of the main challenges we have as surgeons and oncologists and radiation oncologists is to prevent recurrence, because obviously when there's recurrence, that impacts patients in multiple ways, functionally, and most importantly, survival-wise. So you can see here that in general, over 40% of patients who undergo resection of a brain metastasis experience a recurrence of that metastasis, so a high number. And on top of that, there is a phenomenon fairly common of rapid recurrence, such that after you remove the tumor, it may grow back over the course of days into weeks into basically what you had just removed initially. And we see that in some particularly aggressive types of brain cancer, especially glioblastoma. And there's also an entity known as meningioma, which is not classically referred to in any way as malignant, but there are more aggressive types of meningioma that vault it into that category, where recurrence can be a very difficult thing to deal with. So what is one of the strategies that we utilize to prevent recurrence after surgery? And we'll get into that in a little bit, but just giving you guys a quick overview of how these tumors look on MRIs. So we see here all the way to the left, we see what's called a low-grade glioma, and that's typically in one of two categories, referred to as either an astrocytoma or an oligodendroglioma. To the MRI image just to the right of that, which is the second image in the sequence, we see more brightness within the mass. That's contrast uptake. That's more indicative of a high-grade glioma here, glioblastoma. To the slide right, to the right of that, we see a meningioma, different contrast pattern arising from the surface of the brain. And then you see a fairly typical pattern of brain metastases, smaller, though they can be very large, scattered, both hemispheres, different locations. And so these are very common appearances of what we deal with surgically and also in terms of radiation. In general, the basic concept is this: we remove as much of the tumor as we safely can. Even if we remove everything that the MRI shows, we know that there's microscopic disease, infiltrative projections, if you will, that escape our ability to detect even with magnification intraoperatively, as well as MRI. So we know that that patients undergoing these operations will benefit from radiation to the surgical bed. We know that that will prevent recurrence in some cases completely, or at least delay the time to recurrence. Traditionally, that radiation is delivered as what in the form called external beam. There are many variations on that, but that very basic idea is that you basically stick your head into one of these machines, and the machine delivers radiation externally to the target. And the variations on this range in terms of the radiation platforms that are utilized, the specificity of the radiation, sometimes even the type of radiation, whether it's photon or something you may have heard of more, that's becoming more in vogue, proton. And invariably, that radiation happens a few weeks after the operation, primarily because you want the wound to heal, but you also want the patient to recover a little bit from that surgery. But as you might just develop a sense, either having gone through it or just hearing me talk about it, seems like a delay is probably not the best idea when we're talking about malignant disease that grows fairly rapidly. And so that's where the concept of brachytherapy really enters the equation, where we're talking about delivering a form of internal radiation, not the external beam, but radiation that can be implanted at the time of surgery and begin acting immediately. GammaTile, in my view, is the most refined and advanced form of that technology. To describe it in general terms here, it consists of 4 very small seeds that contain the radiation. They are spaced out within that bioresorbable collagen tile that you see displayed there in the forceps. It's basically a postage stamp in terms of size, and that's the analogy I use for patients. We implant these right at the time of surgery. So in your mind, envision the act of removing a tumor. There is a cavity where that tumor was, and along the walls of that cavity, as you might suspect, despite our best efforts, there is typically microscopic disease. And so we line those walls with these tiles. That way, immediately, radiation is delivered to the walls of the tumor and whatever residual cancer cells may be there, thereby killing those cancer cells and lowering the likelihood of recurrence, or at least delaying the time to recurrence. There are also other benefits of it. We have emphasized here on this slide the immediacy, which obviously has benefit because we don't want to delay, but also the convenience of it for a patient to have basically the surgery and radiation done in one sitting, as opposed to having to come back weeks later, which can be very problematic for certain patients who may live alone, who may live an hour and a half from our medical center, or whatever the case may be. Typically, we have to repeat an MRI before the scheduled radiation treatment because things have changed. The cavity has evolved. So these things, these logistical considerations are also eliminated by the fact that we can lay down this gamma tile at the time of surgery. In addition, we're not dealing with hair loss, which is something that we often see in some of the radiation treatments that we prescribe. And it's a much more targeted field because it's delivered at the time of surgery under direct visualization, as opposed to repeating an MRI a few weeks later and having to trace out what can become a more challenging cavity to define in that setting. So benefits of the therapy, again, we've gone over this just over the last minute or so, but we as neurosurgeons can place these tiles at the time of surgery exactly where the tumor existed. And so we have that real-time validation and verification of putting these tiles exactly where we know the tumor once was. It's very targeted because of that. And so in the areas where the tumor is most likely to recur. And for that reason, it's much less likely, I should say, to damage the surrounding normal brain. And that's always the push-pull of the surgery that we perform. We want to get as much of the bad out while preserving the good. And in some parts of the brain, we have liberty to do that. But in other parts of the brain, we don't. And so using something like this, especially in those areas where we know we're coming up against some critical functional tissue, is a nice advantage. And then this is something that you really, with very few limitations or restrictions, can go about in your daily routine after having this implanted. So who are the candidates for gamma tiles? So it's FDA cleared broadly, the indication for newly diagnosed malignant tumors and recurrent tumors. I think one of the beliefs commonly held among neurosurgeons and radiation oncologists is that this is more of a recurrent therapy. But as you could tell from how I've described it, we are often utilizing it. In fact, that is my strongest indication for when we're first encountering these tumors. That's when we want to really kick the tumor while it's down. But of course, in the recurrent space, it has major advantages as well. So this technology is for patients who require brain tumor removal. That is not every patient. There are times where the tumor may be small enough that the patient can benefit from some form of targeted external beam radiation only. Okay, so a necessary precondition to gamma tile may seem obvious, but bears repeating. The patient has to undergo surgery. They have to undergo surgical removal in order for the gamma tile to actually enter into the equation, physically enter into the cavity. So we're talking about newly diagnosed malignant brain tumors. We're talking about recurrent brain tumors, malignant, but also you'll see there listed recurrent meningioma, which is often viewed as a benign entity, but can recur in ways that can make it behave basically just as bad as any type of malignant brain tumor. So this is the kind of technology that if you, a friend, family member, what have you, has this kind of, any of these kinds of tumors, this could be a therapy that's available to you. I'll go quickly over the clinical studies, which are very promising. You could see up here at the top at major institutions nationally. These are really some of the big name players in oncology and neurosurgical care. You could see that the success with treating recurrent, previously irradiated metastases, so these are patients who have undergone radiation and then get surgery to remove this failed tumor, failed in that it's still growing despite the radiation, and then the gamma tile is lining the cavity after that. These are very high success rates in terms of control. 80% at 12 months of no regrowth at the Perreault. Sloan's paper quotes 92% of patients no regrowth at 12 months. And at the Miami Cancer Institute, borderline hard to believe, but 100% of the patients they reviewed, and these are relatively small sample sizes. For newly diagnosed metastases, which is the space that I've gotten most involved in, University of Minnesota, which has been a very big user of gamma tile, show a significant percent of local control at 6 months using gamma tile. So very promising features. For recurrent glioblastoma, Miami also shows, as well as along with their newly diagnosed metastasis series, significant progression-free survival. That's what the term PFS refers to, OS refers to, overall survival with resection and gamma tile compared to those patients who are not receiving gamma tile. So we're seeing very promising early numbers. The numbers aren't even so much early anymore because the technology really has been available now, getting into the 6+ year range. So I'm happy to expound on this a little bit more. The emphasis of my talk, I think, was a little bit less pure kind of clinical result and more about kind of what this is about, who may benefit. There are ongoing clinical trials that we also very much encourage patients to get involved with. And as I tell patients, some of these trials may directly benefit you, but I often find that patients feel when they're afflicted with these tumors, a real humanitarian urge to help future patients. And that's often what these trials will do in collecting this critical information about patients who undergo these operations and receive GammaTile, that it can help us figure out how best to use this, refine this, and who really can benefit from this in the future. So we now are seeing GammaTile in over 100 hospitals across the country. Was brachytherapy in the brain was a very niche endeavor. This is just a tribute to the fact that it is really expanding, and I think there's a lot of enthusiasm among neurosurgeons and radiation oncologists who are partners in this, with almost 1,500 patients treated with this to date. So it's really ramping up. And I'm happy. These are just some general comments about the technology, and I'm happy to take any questions from any of you here. And thanks so much again for the forum.
Thank you, Doctor. If anyone does have a question, you are more than welcome to ask a doctor right now, or you can type your question into the chat box and I will hopefully get to it. One of the questions that has come in, we have a lot of people actually joining us from the UK, Germany, but also Canada today, as well as all over the United States. When will this treatment be available in Ontario, Canada?
Yeah, I should know the answer to that, but I just don't. It's a simple thing for us to figure out. I just probably have to ask one person at the company so we could get that answer to you. I don't know if anyone from GammaTile is on, whether or not they can answer that.
Yeah, there's a few people from GammaTile on. Does anyone have the answer to that question?
Hi, Dellann, this is Lori. No, at this time, we don't have any plans in place to expand to other countries. Like Dr. Hanft mentioned in the presentation, we are in over 100 hospitals right now, but there's still so much to cover within the US that we're really laser focused on getting into more hospitals and helping more patients in the US at this time. As soon as more information is available, we'll be sharing that when we're going to go out of the US.
Thank you, Lori. Thank you.
I see a question here in the chat.
Yes.
About GammaTile relevant for multifocal tumors. This is a great, really advanced question. It depends a little bit on what type of tumor we're talking about. So I'll tackle it from two angles. If we're talking about multifocal glioblastoma, the answer to that is typically going to be a no. Because GammaTile, at the end of the day, is a what you can regard as a focal therapy. And a multifocal glioblastoma is, as you might imagine, a more diffuse process. So it's not typically utilized in that circumstance, especially since, just think about it from a very kind of literal, practical standpoint. We're removing tumor in one spot and laying down GammaTile. And then those other spots we're not necessarily operating on those spots. But let me tell you how it may apply beyond glioblastoma. In metastases, which are often multifocal, if you want to use that terminology, there are times where I will remove in a patient, let's say, who has 3 or 4 metastases. If there's a dominant metastasis in terms of size, swelling, and symptomatology, I will remove that and line that cavity with the GammaTile and then subject the other non-surgical tumors to more standard radiation. So that is kind of a, if you will, a hybrid circumstance where you can still utilize the GammaTile and external beam. And there are reasons to do that. Many of the reasons which I laid out earlier. We still believe that the power of the GammaTile, the immediacy of that treatment, is significant enough to warrant its inclusion and removal of a metastasis in a patient that has other metastatic tumors as well.
Thank you. There's a really good question in the chat box. Jenny just posted it. Do you see it?
Yes, what is your recommendation for clinical trials of gametol and exclude? Yeah, it's a good question. You know, these are one of the things that we deal with for newly diagnosed glioblastoma, particularly maybe something you guys have heard of here, known as Gliadel. One of the deterrents for Gliadel, which is something that I'm not saying anything negative about, I just haven't incorporated into my practice, but I know one of the deterrents over the years has been if someone has Gliadel placed at their index operation for glioblastoma, it can be an exclusion for future clinical trial enrollment. And that is a deterrent for both neurosurgeons and patients, obviously. It depends on the circumstance. I personally, and we're talking here about high-grade gliomas, I am not utilizing gametol much in the upfront glioblastoma situation. There is a trial, which I had on the slide before here, known as Gestalt, which is looking at that. And there are people who do utilize it for that. It hasn't been my application of the technology to this point. So I've not run into what this person is really asking about very intelligently here. Now, if you're asking about in the recurrent setting, right? So there's a recurrent glioblastoma, you put in gametol in that patient and potentially exclude them from a clinical trial. Well, I will tell you that, yes, nearly automatically, if you are putting in gametol or even not, you are taking that patient out of some type of clinical trial. So you have to consider what the clinical trials are, what that patient could potentially qualify for. And there are going to be circumstances where you feel that gametol might be a superior option to a patient just getting recurrent surgery and enrolling in a trial. It's going to be something that you have to weigh with the patient and invariably at that moment the neuro-oncologist. So it can be a tricky thing to navigate, and that's why this is a very good question.
That's a very good question. Thank you, Doctor. Do you mind putting on the slide again that if people have questions such as where can I have access to gametol, so that there it is. Awesome. Yeah. That's a really important link, a URL. I also want to mention, of course, our direct services team here at the End Brain Cancer Initiative can certainly help you identify the closest site to you, as well as make an introduction for gametol. So please utilize our services as well. I want to thank you so much. This was very enlightening to all of us. What we want to see is prior to surgery, we want to see our physicians and our rad oncs having a conversation with patients who are diagnosed with of course, GBM, recurrent GBM, low-grade gliomas, metastasized disease, about gametol. What we don't want is for patients to learn about gametol after the fact.
Right.
So we need to get loud about that. There's a lot more disease education, awareness, and outreach around gametol that needs to happen. And I know there's a lot that GT Medical is doing with the healthcare provider population. But it is the patient voice that will also change practice. This is an FDA-approved treatment. However, we know a lot of people do not have access to it. So today's presentation was really appreciated, and I know it will increase access for this patient population. Thank you so much.
Happy to do it. I mean, look, you guys know this better than I do, right? You become your own best advocate, right? When you get this diagnosis, the people who are going to help you are yourself more than anybody, and obviously some family, and you almost become an expert in that disease. I mean, I have some patients who I feel genuinely know more about the condition than I do in certain ways. It's wild, but that's what it should be. And sometimes the process unfolds so quickly it's hard for you to become an expert, especially being a non-medical people so quickly. So that's why we have forums like this, and we try to spread the word as best as we can. And that's why I think, Dellann, what you guys are doing here is so
Absolutely.
critically important.
Absolutely. We really appreciate our partnership because it helps us increase the patient education, awareness, and outreach, which simply increases access. So that's kind of what we're all about. Okay, we must move on. That was an excellent presentation. Thank you so much.
Thank you. I'm going to try to figure out how to, yes. Did you get the screen back? You got it. Wonderful. Thank you.
Yes, there is Dr. Haynes' contact information. Please feel free to reach out to him as well if you have additional questions. He's a great resource. Thank you so much, Doctor.
Thanks for having me. See ya.
Absolutely. Bye-bye. We have Eric Perreault with us, who is the CEO of KAYTO. There he is. He actually leads the biotechnology company in its mission to revolutionize cancer care by harnessing the power of functional precision medicine. Today, Eric will provide education on KAYTO's 3D Predict test, which helps predict which treatment is likely to be the most effective for your specific tumor tissue for a personalized medicine treatment approach, which is so exciting. You know, I feel like this is me personally speaking. When we're talking about GBM, it is a personalized approach because GBM is so many actual different types of tumor tissue and cancer. So we need to be thinking about a personalized approach with GBM and recurrent GBM well before surgery. Eric, are you ready?
I am ready. I can share my screen.
Absolutely.
And just give me a yay that you see it.
Yay.
All right. So first of all, let me say congratulations to Patty. And maybe we can find out who he's rooting for in the NHL playoffs. I am from Boston originally, so I'm a big Bruins fan. And but I lived in San Diego for 18 years and went to many Gulls hockey games as well, Patty. So glad to see that San Diego hockey is continuing to thrive. Great stories from Jessica and TJ as well. Really appreciate hearing patient stories. It's really what motivates us as a company. And of course, Dr. Simon using GammaTile. A lot of people think that there hasn't been innovation in the brain cancer space, and there actually has been. And I see a lot of you wearing your Optune devices on this call, plus GammaTile, and then I think innovation with KAYTO. I think we're starting to see that we're making progress in the brain cancer space. And functional oncology is such an important aspect to all of this. My mother herself went through stage 4 bone cancer, and getting information from your cancer cells can be really powerful. And that's what KAYTO is all about. Our primary focus early stage as a company has been in the brain cancer space. And we're now doing some work in women's cancer. And I'll talk a little bit about those, but I'll use that more as an example than anything else. Here's our mission statement. And I think, you know, after being in the diagnostic industry now for 30 plus years, what diagnostics are providing is information. And powerful information is information that you didn't know before and you can take action with. And that's what I think 3D Predict and KAYTO is all about. But essentially, we're providing confidence with life-changing cancer therapy decisions. And I hope in my talk in hopefully just about 10 minutes, be able to illustrate what that information is and how we're doing it so that everyone on the call can understand. I think the big question that needs to be answered, and it needs to be answered with a high level of confidence, is the standard of care chemotherapy that my clinician is going to choose, will it work with my cancer? And everyone's cancer cells are different. They're very unique. So figuring out the answer to this question is really important. And what we know about glioblastoma and GBM is that TMZ or Temodar doesn't work for a lot of patients, is pretty non-responsive for about 60% of patients. So it's great if it works for the 40% or so, but knowing if it's not going to work for your tumor and for your cancer cells, and by work I mean does it kill the cancer cells, is really, really important. And even with a cancer like ovarian, where the standard of care therapy does work much more effectively, it works for about 70% of patients. Knowing if you're in this 30% group is vitally important. And we think that using direct chemo drug interaction with your actual live cancer cells is going to open the window for providing this information to your team. So let me talk a little bit about that and what 3D Predict is and how 3D Predict works. And it's really about answering key questions. Will the standard of care therapy kill my cancer cells? If it's yes, then obviously that's the chemotherapy that should be chosen. If it's no, are there alternative chemo agents that will kill my cancer cells? If the answer is yes, then potentially you're going to go down the path of using alternative medications, something other than TMZ, for example. If it's no, then are there clinical trials, a new drug path that are potentially available to me? And if there are not, then maybe it's time for focusing on quality of life and other tools like Optune and things of that nature. We really believe that having a confident answer to these questions is really obtainable by bringing in QIAtech and 3D Predict. So let me show you what we do and how we do it. We have a CLIA certified lab. It's 25,000 square feet in Greenville, South Carolina. And what we're doing is during a normal resection surgery or biopsy, we're taking about the size of a number 2 pencil eraser directly from your tumor. And in that number 2 pencil eraser size sample are millions of your live cancer cells. That is being shipped in overnight using UPS Healthcare in a special solution to keep your cancer cells alive. That is being shipped to our laboratory in Greenville, South Carolina. And then when it arrives, our wonderful laboratory team create 1,000 microenvironments using your live cancer cells. And picture these microenvironments being like these little circles here. They're little tiny wells. And in each one of those wells, we are creating a spheroid, which is basically a baseball, a ball-sized object. And that spheroid is floating in that well, just like it would in your body. That is all happening on day 1 of arrival in our laboratory. And then on day 2, we are introducing directly to these wells a panel of 12 chemotherapy drugs that are available for glioblastoma. And we came up with that panel by working directly with neuro-oncologists. So the neuro-oncologist said, outside of Temodar or TMZ, here are the 11 other drugs that we most normally use if we're not using TMZ. And all of those are introduced into each one of these little wells, up to 1,000. And in each one of those are your live cancer cells. And then about at day 7, we're actually looking to see if those particular drugs, which ones actually killed your cancer. And what we're saying is that if your cancer cells were killed in our lab, we're predicting that they will die in your body. And so when the doctor gets the report, they're getting a green for a response, meaning that the drug actually worked to kill your cancer. A red is no response, that the drug did not work to kill your cancer. And a yellow, that is a moderate response. And we're returning that report back in 7 to 10 days. Prior to you actually starting chemotherapy. That's why we talk about days, because obviously if it was 20 days or 30 days, that's too late because you've already started chemotherapy. So we want to give the information back as early as possible to inform your clinical team. And we think it informs decision-making. So obviously standard of care is TMZ, but for elderly patients, the standard of care in the guidelines can be TMZ or radiotherapy alone. We know that TMZ doesn't work for a very high percentage of the patient population. And what we absolutely know through our data is that if you are a predicted responder to TMZ and you get TMZ, you have a significant survival advantage or progression advantage as well than a non-responder who got TMZ. And I'll share a little bit of the data. I won't get too heavy into the data, but I'll share a little bit. We have 2 studies with our test. And what we see is that the non-responders who got TMZ progressed much earlier than the responders who got TMZ. So if your cells were actually showed that TMZ worked to kill your cancer, you progressed much later than the non-responders progressed. This is a very busy slide. So let me walk through it. And this is why I like to use my laser pointer, because I can stay focused and show you the areas that I'm talking about. And I'm actually going to start right in the middle. So this 69%, this is clear evidence from both of our studies. And let me explain to you what we mean by this. So it's clear evidence from 2 studies of longer life for responders versus non-responders. What we saw in our 2 studies is that 70% of the patients where our information said you were not going to respond to TMZ, they progressed, meaning they reoccurred in their disease prior to the first responding patient to TMZ progressing. So that's a substantial piece of information. So if you're getting a response indicator from 3D Predict, that's you do want to use that drug versus if you're a non-responder. The top section here is about positive predictive value, which is a very important laboratory diagnostic piece of evidence. This is a 98% positive predictive value, which from all of my experience in diagnostics is off the charts high, which basically means that out of 100 patients that got a response, the test was correct 98 times for 98 of those patients. And just in the comparison, another cancer diagnostic test that's not associated with GBM, but is used for non-small lung cancer is called PD-L1. The positive predictive value for that test is 36%. So just to kind of give you a comparison of how strong a performance 3D Predict platform is compared to other cancer diagnostics. And then lastly, down here on the bottom, I'm sure all of you have heard of methylation status or MGMT. This is a diagnostic test that I'm sure most of you on this call received as part of your initial diagnosis. And the reason why they use this is because if you're unmethylated, that is an indicator that TMZ will more than likely not work. And that it's also in the guidelines. And what our data shows is that 3D Predict is actually a better indicator than MGMT. We showed non-concordance, meaning 27 out of 59 patients, the MGMT result did not match what we were seeing with 3D Predict. So, and it makes sense because MGMT is not using your live cells, where 3D Predict is actually using your tumor cells to get the power out of those to see if the chemotherapy actually kills your cancer cells. Just a couple more slides just to kind of show you, these are not all the sites that are using our test, but these are some of the earliest adopters and some of the most impactful sites that we've already seen using our test. In the Pacific Northwest, up in Washington State, Swedish was one of our earliest adopters. Virginia Mason also is an early adopter of our test up in the Pacific Northwest. We have 2 Mayo Clinic locations that are using our test. Some very prestigious universities like University of Colorado, the Ohio State University, Oklahoma University are sending in patient tissue, as well as Miami Cancer Institute down in Florida which Dr. Simon also mentioned some of the great work that they've done with GammaTile. So these are some of the locations that are already ordering our test. We are earlier than GammaTile, so we're around 27 to 30 locations that are sending in tissues in the US. But please don't make that don't let that cause hesitation in you reaching out to KAYTO. If your institution is not listed here, or if we're not in your institution yet, you can connect with us on our website, fill out our contact form, and we'll reach out directly to your team and have a conversation with them so that they know how to send in tissue to our laboratory.
Excellent.
Just two really good quotes. Dr. Margala, results from 3D predict-glioma testing is used for our clinical decision-making. He's from the Mayo Clinic in Phoenix. That's probably the best endorsement you could potentially have, is that they're actually using this now to decide what chemotherapies. And this is just to kind of show you that one of our earliest adopters at the University of Arkansas, this is Dr. Annalise Rodriguez, who's a fantastic neurosurgeon. They're very close to now sending in 100 tissues, so serving 100 cancer patients from the University of Arkansas. Very, very impactful. And I really appreciate being able to spend time and talk to you all today. And this is our website, kayatech.com. Lots of really good information on there, patient information. There's a patient tab on there specifically for you to go in and take a look at. And then certainly you can contact us at any time if you have questions.
Outstanding, Eric. Thank you very much. First of all, I want to compliment you on your patient-friendly slides. Like it a lot.
Great.
Those are great. Easy to understand. Obviously, I think they're graphically beautiful. And that was a really great presentation. So as you can imagine, there's lots of questions about, is this test covered by insurance? And if not, how much does a patient have to pay out of pocket?
Yeah, it's a great question. So and this is actually, you can get all of this information. We have a great flow chart that can be provided to you to show you how KAYTO supports you through the reimbursement process. So we do everything for you. So we will file to your insurance company on your behalf. We will go through, if it gets denied, we go through the appeal process all the way through to the end. We offer financial assistance as well. What I can tell you is that anyone who has used the financial assistance program, so they've gone through the entire process, which usually can take up to 145 days, believe it or not, to go through the entire appeal process with an insurance company. Mm-hmm. We have not had a single patient pay anything out of pocket. So we have a very generous financial assistance program. Our goal early stage is to get complete Medicare coverage. And once Medicare CMS says we're going to cover you, then you don't even end up going through the appeal process. You get approval. So at this point in time, we're really trying, and we're succeeding, is not burdening any of the patients to have to pay anything out of pocket. There has been about 2 occasions where we've gone through the process and there's been a copay, but all of the copay has been under $500. We have not had a single copay that's over $500. And we accept essentially whatever the insurance company will pay. Our Medicare fee schedule for the entire experiment, the entire 3D Predict, is over $3,000. It's very similar to what CMS is paying for next generation sequencing. And that's what we're striving for to get paid for. So I would say go onto the website, get the flow chart, and know that more than likely, if you did have to pay something out of pocket, it would be very, very minimal.
Thank you very much. That's totally awesome. Oh my gosh, there's a lot of questions that came in. Really quickly, regarding Medicare, KAYTO does not, NOT does not require patients with Medicare coverage to submit an advanced beneficiary notice, correct?
Yeah, that's correct. So we're in conversations with Medicare and CMS. We know that we're going to get denied for Medicare, and if you're a Medicare patient, you will not be charged for the test. But CMS has encouraged us to submit every claim until we complete the process, right? So we will still submit your claim to Medicare. We know we're going to get denied, and we know we're going to write it off as a company. But that's part of the journey of getting complete coverage from Medicare. I know it sounds a little bit crazy, but it is part of the process of what we need to do as a company. So we're doing that on your behalf, and you will not be charged anything if you're a Medicare patient.
That process is also part of the process, to be honest, that we need you to do as far as advocacy organizations, because when it's time to get involved, you know, then we've got a clear history of what's been happening. I want to tell everyone that the financial assistance program, all that information, of course, is on KAYTO's website, but the phone number is 1-866-512-2943. 866-512-2943. Are you at liberty to say which insurance companies are most friendly related to
Yeah, well, sure. The bigger bucket is where we're having our most success is Medicare Advantage. And that's a combination of Medicare plus commercial payers. And the ones that we're having the most success with are the biggest players. So Aetna, United, Blue Cross Blue Shield have been the ones that we've had the greatest success with so far. And again, you know, if we end up going through the entire appeal process, and that means that we go back to your clinician, get additional medical record and resubmit to the insurer. And we're doing that on your behalf. So it's hands off for you. And again, if you're using the financial assistance, we have not had a single patient pay anything out of pocket. So, I would really encourage you that, you know, for a recurrence and where you have a little bit more time to plan, certainly reach out to us and talk to us ahead of time, and we can walk you through the entire process.
Is there a veterans program?
Not yet.
Not yet.
It would fall under the same program that we have for all regular patients as well.
Okay. Okay. I don't know if you can see the questions. I am looking at the time, but there is one more question, and it's actually a couple of questions within.
I see it. I actually do see it, and
Okay.
it's a really good question. I'll go really quickly, and then we can follow up Anne's question in particular. So the question is, some companies test cancer cells in mice first. How is KAYTO approach doing this better? So I think the reason why it's better is we're actually using the patient's live cancer cells. So you're getting direct interaction across 10 different levels for each drug of the 12 that are on our panel. And the drug is directly interacting with your live cancer cells. So I like to say, and this is kind of bold CEO kind of talk, it is the most personalized approach because we are using your live cells. And I think that's the difference. All of the drugs that we're using are FDA approved chemotherapies that are on our panel. We do have some PARPs that are on our panel, and you can see the entire panel listed on our website. So they're off label in the sense that some of them they don't have an indication for GBM, but they're all FDA approved drugs. So they're all drugs that have been shown to kill cancer for other indications and sometimes for GBM. Stem cells, there's lots of talk about stem cells. I think it's definitely some promise there as well. I know that there are some companies that have tried to do what we're doing using stem cells. And the challenge is that you have to do a amplification and it can be challenging to get the turnaround time. I think what we're doing is a little bit simpler, where we're taking all of the cells in the tumor and taking advantage of all of them. So But I think there is promise down the road for stem cells for sure. And I look forward to seeing more advancement there.
Thank you, Eric, so very much. I also want to say thank you to KAYTO for your investment into, you know, the brain cancer space. Really quickly, is it just adults or are we in the pediatric space as well?
Yeah, for our initial studies, it was just adults, so
Okay.
18 years or older. But I do think that's an opportunity for us to you know, take a look at as an organization. I should tell you that there is going to be an expansion of our brain space, and I didn't show this on a slide, but we are moving forward with low grade as well as brain metastasis cancers to the brain, and that we're moving forward with very quickly. So that's where the primary cancer might be lung cancer, and then there's a brain met that happens later. And we're working actually with Miami Cancer Institute, just like Amitile is, on the brain mets effort. They're such a great group. So
They are a great group.
really
Yes.
helpful.
Fantastic. That's all really good news and encouraging. Thanks so much for talking to us today and yet again giving us another diagnostic to increase treatment options and of course increasing personalized medicine. Thank you, Eric. Really appreciate it.
Thank you, Dellann. Thanks for all you guys do as well. It's great.
Of course. Absolutely. Thanks so much. I want to introduce Dr. Jonathan Dewey. Jonathan is with Servier Pharmaceuticals. He is the Senior Medical Director for Solid Tumors. He brings experience from previous roles at Servier, of course, Sonify, and Biogen 1. He is currently involved in the, I always say this wrong, so sorry, vorasidenib expanded access program, which we'll maybe learn a little bit more about. And he's going to talk to us today, which is such good information, what IDH1 and IDH2 markers are. And he's specifically going to be talking about IDH1 and IDH2 mutated gliomas. And this is exciting because this is a whole different area of potential treatment option based on markers. Jonathan, are you joining us?
Yes, I'm here, Dellann. How are you?
I'm great. How are you?
Good.
Nice,
Good to see you again.
Nice to see you.
Thanks so much for the introduction. I don't know if Patrick is still on the call, but I wanted to say hello to my fellow Utahn, who I saw that on his jersey that he played hockey at University of Utah.
He was the goalie. He was the goalie.
Yes, I saw it. No, that's great. So as you can see from my background, actually, I live in northern Utah, even though I work for a Boston-based company. And I did my master's in biomedical informatics at University of Utah. So yeah, hello to Patrick. Congrats to him and the other National Hope Award nominees, and really congrats to all of the patients and their caregivers who are still fighting brain cancer. So thanks to you and thanks for all that you do. I am going to start my presentation with some disclaimers. Of course, let me share my screen. So the disclaimer that I have to start with is just to say that this presentation is for educational purposes only. Servier does not have an approved medication for the treatment of glioma, and that only approved uses and products can be represented as safe and effective as defined by the approved product labeling. Now, the other thing I wanted to do, Dellann, is to apologize for the nature of my slides. They were originally approved for the use of educating providers. And I noticed your thanks for the more patient-friendly slides. So I'm going to, first of all, do my best to focus everybody just on the parts of the slides that are most important. And then also make up for it by starting with an analogy to kind of illustrate why it's important to understand the biology of tumor cells and how we use that in developing treatments for cancer. And that analogy actually has to do with living in northern Utah as well. There are a lot of benefits to living in a more rural area, as you can see from my background. You have some natural beauty. But one of the disadvantages is that weeds grow very well where I live. And when I'm on the road for a while, as I have been recently, they can get out of control. And I was doing some long overdue yard work this week. And there are certain areas of my yard where I don't have anything of importance growing. And in those areas, I just have a lot of weeds, and I can use a weed killer that just kills all plants, and that's fine. But in my lawn, on the other hand, I have grass, which I very much want to keep, but I also have dandelions, unfortunately. And there I can use certain fertilizers or sprays that target only the dandelions that I don't want in my lawn, but that don't target the grass. And that's possible because somebody somewhere took the time to understand the molecular nature of dandelions and how it was different than grass, so that I could use a targeted therapy, if you will, for my lawn and target only the dandelions. And that's what understanding IDH mutations really does for us when it comes to developing treatment for brain cancers. The goal is to be able to identify ways that brain cancers are different from normal cells and target those differences so that we can prevent or slow the growth of the brain cancer without doing damage to normal cells in the body. So with that, I wanted to dive in and provide a little education on the IDH mutations specifically and how those help us understand brain cancer cells. IDH mutations were first discovered as being linked to glioma in 2008. And if I can take you back to high school biology, in this middle section, you'll see a bunch of A's and T's and G's and C's, and that represents the DNA of the tumor cell. And in certain locations in that DNA, there can be mutations in these genes, and those mutations lead to changes in an enzyme called isocitrate dehydrogenase. And there are different versions of that, IDH1 or IDH2. But those mutations and those differences lead to changes in the metabolism of the cell and lead it to behave in ways that are more like cancer. And importantly, even as early as this publication in 2008, as you can see on the far right, the researchers noticed that when they were looking at what was then classified as glioblastomas, the glioblastomas that had these IDH mutations tend to have a different prognosis than the glioblastomas that did not have the IDH mutations. The cancer cells with the mutations, or the patients that had tumors with the mutations, tended to have a longer survival time than the patients that did not have the mutations. Subsequent research helped scientists understand why that's the case. The cancer cells that have the mutated IDH genes lead to an overproduction of a molecule called 2-hydroxyglutarate. And that's a really long word, but what it essentially comes down to is that that overproduction of 2-hydroxyglutarate has an impact on the cancer cells that makes them more cancer-like. It can lead to unchecked growth of the cells. It can lead them to actually suppress the body's normal immune cells that would otherwise be able to detect and kill the abnormal cells. And in this way, the IDH mutations promote the development of the brain cancers. Now, in the last decade, the importance of the IDH mutations has been increasingly reflected in the guidelines that physicians use to classify disease and to determine the best treatment options for a particular patient. In 2007, before the IDH mutations were discovered and linked to glioma, the grading of gliomas was based mostly on the features of the tumor cell that a physician could see while looking under the microscope. But as of 2021, the molecular characteristics, like mutations or other genetic abnormalities, are recognized as a key factor in determining the grade of a glioma. And so now, if you look at the different grading or the different classifications for adult type diffuse gliomas, you see that there are really only 3 different categories. And one of the most important factors in determining which category a tumor falls into is whether or not there is an IDH mutation. In fact, this is so important that if there is no IDH mutation in an adult type diffuse glioma, it is now automatically classified as a glioblastoma grade 4 tumor with wild type IDH. Wild type means there's no mutation. Whereas if there is a mutation, then it's either an astrocytoma, or if there's a mutation and a different genetic abnormality, which is called a 1p19q codeletion, then it's an oligodendroglioma. And the prognosis of each of those cancer types is different. Each of them has a different trend in overall survival or even progression-free survival. And as these graphs show, the gliomas that have both an IDH mutation and a 1p19q codeletion have the best prognosis. Now, one thing that it's really important for physicians and patients to understand, and in fact, this is something that Dr. Hanft mentioned in his presentation earlier this morning, is that while these tumors can often be treated pretty effectively with surgical resection, the tumors are diffuse, and as he described really well, there are these microscopic parts of the tumor that you actually can't even see on MRI with the magnification, but they're still there. And so it's really important for patients and providers to understand that even if you have what's called a gross total resection, that there are still cancer cells there. The other thing that's really important for patients and physicians to understand is that those cancer cells are there and they're always growing. The growth is pretty continuous in these tumors, regardless of how much of the tumor was removed surgically. But what does affect the rate of growth is actually the molecular makeup of the cells. So there are certain molecular changes in a cell that will lead it to grow more quickly versus more slowly. And those are some of the factors that are now coming into play with the tumor classification and determine whether it's grade 2, grade 3, or grade 4. And that's even within an IDH mutated tumor. There are other changes that can lead an IDH mutated tumor to grow either more slowly or more quickly. So the last thing that I want to communicate, and this just goes back to kind of that analogy of whether you can treat something like my lawn with a targeted therapy or not. And the way that you can do that is by understanding what's going on molecularly with the cell. And so I won't go into all of the details here, but I'll just say that there are a variety of molecular pathways within IDH mutated tumors that provide an opportunity for us to attack this tumor cell without or with minimizing the negative impact on normal cells. And IDH mutations are one of those key changes. So in summary, IDH mutations are really important in the development of some gliomas, and the presence of the mutation has a really important implication for disease prognosis. These mutations can often, or they do, affect the treatment choices that a physician will make. These tumors can often be removed, at least in part, by surgical resection, but the cancer is always there and will continue to grow over time. And understanding whether or not a brain tumor has an IDH mutation is really critical to understanding the prognosis and the best treatment options for that patient. And importantly, and the reason why this matters so much to patients, to their families, to physicians, is that hopefully with this knowledge, we can develop ways to target tumors in a way that allows us to spare the normal function of the brain while effectively slowing the growth of the tumors. And with that, happy to answer any questions.
Thank you, Dr. Dewey. That is really great. Thanks for okay, so sometimes people, patients, caregivers, family members get frustrated, right? About the lack of evolvement in the treatment of gliomas, low grade and high grade. So what you talked about today is definitely a step in the right direction as far as how these treatments, how these tumors can be treated in the future. So for me, as a patient advocate, that it just excites me so much, right? Because the treatment for gliomas is evolving, and I feel like there's much to be hopeful for. And the importance of the IDH1, IDH2 markers, you know, really are a game changer. And now that we're starting to look at those and the guidelines have changed, you know, I can certainly see patients being diagnosed with gliomas today feeling more hopeful than ever, truthfully.
Yeah, even without a therapy that specifically targets that mutation, just understanding the difference in prognosis with these tumors based on the mutation has already led to changes in guidelines as to how aggressive a physician will be with chemotherapy, with radiotherapy, with surgery. And so that understanding of the biology is already changing the treatment landscape.
Which is so exciting. Yeah, I mean, you know, we always ask for that. There is a question in the chat box, and we'll answer that question, and then we do need to move on. Do you see that, or can I read that to you?
I do see it. It says, what is the difference between Tibsovo and vorasidenib? My daughter is currently taking Tibsovo via compassionate use when the clinical trial closed before she was able to join it. I will say, so first of all, because Servier does not have an approved drug for glioma, right? I can't say anything about safety and efficacy of the drugs, but because the question is specifically about the difference of the two drugs, I can say that they are both designed to target IDH mutations. Tibsovo is specifically targets IDH1 mutations, and vorasidenib targets both IDH1 and IDH2 mutations.
Very cool. Thank you. Thank you. Any other quick questions before we move on? I want to thank Dr. Dewey for your time today. You're right. That picture behind you is really pretty. Did you, do you ski?
I do ski, yes. And I taught my kids and we love it.
My son was there a couple of months ago skiing, and it was the best skiing he's ever experienced.
That's great. I'm glad to hear it.
Fantastic.
Thanks for having me here.
Thank you so much. Dr. Dewey's contact information is right there on your screen. Please don't hesitate to reach out to him if you have more questions related to IDH1 and IDH2. Thank you so much for your presentation. That was fabulous.
You're welcome. It was a pleasure to be here. Thank you.
Thank you. Okay, next up, we have Dr. Vishak Venur from University of Washington and Fred Hutch Cancer Center. He's actually going to talk a little more, keep the conversation going related to IDH1 and IDH2 and what a potential FDA approval for vorasidenib means for future treatment of low-grade gliomas. I'm very excited to hear your presentation, Dr. Venur, and I want to thank you in advance for having some patience as we run a little bit long in this program. Thank you. Welcome.
Well, let's see if I can share properly. Thank you, Dellann, and rest of the team at Brain Cancer Initiative for inviting me. I came, I believe, 2 years ago to give a talk here about clinical trials at Hutch and what we're doing for neuro-oncology. I also want to congratulate all the awardees and nominees for the Hope Award. I think, Hope is the reason why I do what I do, and you patients are the reason why we do all kinds of research and everything that we do for at our center here and as neuro-oncologists. So thank you. I have no disclosures, so I pretty much can talk about almost anything that I practice. I have some slides. We are running late, so we could do several things. We could talk about some of the basics of low-grade glioma and take it from where Dr. Dewey left in terms of all the treatment options that are available. We could talk about some science, but we could also talk about anything that patients want to hear from me in terms of questions on low-grade gliomas, glioblastoma. This is where I live and breathe, and other tumors in the brain. But low-grade glioma, the treatment pillars are three major pillars, and you've heard about a lot about radiation therapy, local radiation therapy like gamma tiles. You've heard about some of the surgical approaches and systemic therapy, which is what I do most of the times. As our surgeons do the surgery, the radiation oncologists are delivering radiation, and then patients come to me for systemic therapy options. But these are the three pillars, and we have to think about what goes first, what goes next when a patient with brain tumors, whether that's high-grade glioma or low-grade glioma, comes to our team. And it really is a multidisciplinary approach, as we have been all talking about. But low-grade glioma is a very unique subset of primary brain tumor. And to be honest, patients with low-grade gliomas are often younger patients. They usually are either starting their career or they're in their journey through having family or having young kids. And these are patients in the age group of 20 to 40. That's kind of the age group where these patients with low-grade glioma present to our clinic. Usually seizure is their first presenting symptom, but they could also have other neurologic symptoms like stroke-like symptoms and things like that at the time of presentation. So they do present unique challenges, and taking care of patient itself, patient's family, caregivers could be different for patients with low-grade glioma than glioblastoma, where the median age is a little higher, around 65. So there are different nuances in taking care of patients with low-grade gliomas and high-grade glioma. And obviously, survival curves are different, and I have some survival curves here to show you how different low-grade glioma patients tend to do compared to high-grade glioma patients or glioblastoma. And then Dr. Dewey really mentioned very succinctly and really nicely about the new IDH discovery of IDH mutation, potential for new IDH inhibitors, and we'll talk a little bit about the study that his company conducted, and we'll talk about some of those results and see how that's going to change, or that might change, our landscape in the future. Some of these slides are sciencey, but I'm going to try to break it down for our audience here today, and we may not have to go through all these things, and I'll just hit the highlights of what each of these slides really want to convey. This is really the pivotal study when we are talking about low-grade glioma. This was RTOG 9802. For those who don't know what RTOG is, there are these groups of institutions that have come together and formulated consortium for studies where really there's not a lot of industry support. When we do clinical trials, we need a lot of support from a lot of different industry organizations or philanthropy to run these trials. So NIH, which is National Institute of Health, had these 4 major groups where you could get funding from NIH to run some of these studies. So this was a study which really started enrolling patients in 1990s and presented their final report of long-term results in 2016. And this is a pivotal study for patients who have low-grade glioma, who have had surgery, but have some tumor left behind if they are less than 40 years of age, or if they're age 40 or over, even if they have had all the tumor that is seen in the MRI removed, they were included in the study. They got radiation alone or radiation plus this combination of chemotherapy. And this study really, I have graphs after graphs, and you could look at graphs after graphs, but what it really shows is that patients who get radiation plus chemotherapy tend to do better compared to patients who just get radiation. And these curves are really good. If, in cancer field, we look at a lot of these curves called Kaplan-Meier curves, and there are several of them. What they really look at is how the patients are doing over time and how many of these patients are reaching certain endpoint over time. And for people who are living in cancer field, we really value these trials and value these curves a lot. Clearly, slide after slide is showing that radiation plus chemotherapy do better than radiation alone. Even in patients with IDH mutation, which Dr. Dewey was talking about, patients who get radiation plus chemotherapy do better than radiation alone, whether that is living longer or whether that is tumor under control for longer. So that's kind of establishing a baseline of what is the treatment for patients with low-grade glioma. But we also know that patients who get a lot of radiation end up with a lot of complications. There are complications of cognitive impairment. There are complications where they cannot go back to work. They cannot go back to driving. Their lifestyle changes. They might sometimes need a lot of help from their family to support them through the rest of their journey. So there's a lot of issues associated with radiation, even with newer techniques of radiation, photon radiation, proton radiation. As patients, you might have heard about all these things, but everything comes with side effects. And as I mentioned, we are talking about a younger population where these patients are contributing to the society or having, are either studying. I have patients with low-grade glioma who are in school. I have patients with low-grade glioma who want to have family. So treating them with very aggressive radiation may or may not be the right way to go is a thing that we realized really quickly as we were doing more and more of radiation and chemotherapy for younger patients. So that's where this study comes in, which is the Indigo study, which looked at a specific IDH inhibitor, vorasidenib, for patients who have not had radiation. So what they did is they included patients with some residual tumors, so they had resection and then had some tumor left behind, or they had resection and the tumor came back 1 year after surgery, but no more than 5 years after surgery. They were randomized to receive this IDH inhibitor, which is kind of a lock and key, right? You have an IDH mutation, then you target it with a drug which really targets that mutation versus placebo. And they were looking at several endpoints. And again, this is technical, what endpoints, but progression-free survival, which is tumor under control for how long is what their primary endpoint was. And then they have really nice curves showing that patients who received the drug had median survival, progression-free survival benefit of more than a couple of years and so on. And across the board, there was benefit of using this drug compared to placebo. The drug was really safe and did not have a lot of side effects. When I was one of the investigators in the study, I have a patient still active on the study. I want to just make sure that I mention that. And the patients have been doing really good with very minimal side effects. So now the company, Servier, is trying to get FDA clearance, and there are dates and things like that set up, and that's publicly available. The question is, how do we incorporate this drug when we were initially thinking about radiation and chemotherapy? So these are some of this is really my last slide, talking about what should we think about when we are looking at low-grade glioma patients, and how do we incorporate IDH inhibitor if it gets approved, and if and when it gets approved. And some of these patients who have been on other IDH inhibitors, how do we handle, and so on and so forth. So here are my questions that I've been thinking when I see my patients. When I see patients with grade 3 tumors who are anaplastic and not technically considered low-grade glioma, I often want to get their tumors sampled again or tested again to see if they are really grade 3. Maybe they are grade 2 bordering to grade 3, and they were labeled as grade 3 by people who are not doing biopsies routinely or testing routinely. So there is a lot of room for testing and WHO grading, and that might change over time. I mean, 2016 to 2021, we had a huge change in classification. We expect that to continue as we learn more about these tumors. Then the big question is who should get radiation plus chemo first, or who should get IDH inhibitor first? And there's really no guidance on who are those patients who might benefit with one treatment over the other. And we can talk about that for hours. And I was talking to my colleagues at every tumor board. We have patients like these who come in and we talk about, should we do radiation or chemotherapy? Should we do IDH inhibitor first when it gets available? Then the other question is, how long do we wait after surgery? The study said we should wait for a year for specific reasons, probably related to the trial protocol. Should we really wait for 1 year after surgery? That's something that we have to really think about. For those patients where, who already had radiation and chemotherapy and now have tumor coming back, is there a role for IDH inhibitor there? Or is there a role for IDH inhibitor in combination with chemotherapy and radiation? Something to think about. Then what are the other clinical trials? There are lots of clinical trials which are looking at IDH inhibitors, different kinds of IDH inhibitors, combination with other drugs and IDH inhibitors. So something to keep a track of there is there are lots of clinical trials in this field of IDH mutant low-grade glioma. That's where I'll pause. I can answer these questions on what I feel, but I also want to take time to answer your questions and go from there.
Thank you so much, Vaishak. Someone, there is a question in the chat box. Do you want me to read it to you, or can you see it?
Let's see. I probably cannot see the chat.
Oh, okay. Excuse me. What is the difference between Tipsovo and vorasidenib? My daughter currently is taking, I think
Dr. Dewey tried to answer that question.
Yeah, we already addressed it.
Dr. Dewey rightly mentioned that, Tipsovo is a IDH1 inhibitor, whereas vorasidenib is broad IDH1 and 2 inhibitor. Actually, Dr. Melangoff, who was the principal investigator for the Indigo study, also did a previous study which looked at these two drugs, and these patients had either of these drugs and went to surgery, and they were looking at penetration into the brain, which is one of the huge issues in our field. Yes, chemotherapies work in general, but the problem is chemotherapy works in petri dish. For example, any kind of chemotherapy that we have available, carboplatin, for example, or any of these chemotherapy works really well when these tumors are grown in petri dish. But in humans, where it's in the brain, there are lots of logistical challenges. So this study was trying to look at, let's do biopsies after giving patients one of these IDH inhibitors. And they said that the CNS activity was pretty equal with both these drugs. So there are patients in my practice who are actually right now on Tipsovo, because vorasidenib is not available and these patients have IDH mutation. In the future, though, if vorasidenib becomes available after FDA approval, I'm more open to switching these patients over to vorasidenib, and that's a discussion you should have with your own physicians. And I have that with my patients about that. And when it becomes available, maybe worth considering a switch.
And correct me if I'm wrong, but I believe we're expecting approval by the FDA for vorasidenib. And correct me if I'm wrong, but that is going to be the very first drug that will be FDA approved for low-grade gliomas, correct?
That's all correct. Again,
Okay.
FDA is reviewing this drug yet, so we have to be very honest about that. And FDA has these dates set up. I think the date that they have to review, and this is publicly available information, is by mid to late August, is when they have to give an answer for this drug, which is the reason why I think Dr. Dewey cannot talk about this drug, and I recognize that. But yes, this will be the first. If that goes through, this will be the first drug that could be approved for low-grade glioma. So we are super excited. And this is going to actually create a lot of buzz in the sense that even at last ASCO, American Society of Clinical Oncology meeting, which is coming up in 2 weeks, there was a plenary session on this drug, and there was standing ovation because this drug has been in the making for so long. I know it only impacts a certain subgroup of patients. It's not for all brain tumor patients, but we're making progress. And if one drug gets across and gets FDA approval, the industry interest in our space of brain tumors is going to explode. And that's important for future drug development.
Absolutely. I actually want to compliment your work, of course, but I also want to compliment the work of the End Brain Cancer Initiative, to be honest, related to this particular drug, because the low-grade glioma community reaches out to us as well for help. And so we're happy to help. The thing that's challenging is we don't really have anything for these particular patients yet, except for, as appropriate, a clinical trial. So the Indigo trial was incredibly, from a patient advocacy organization, was incredibly important to be able to educate patients about and then help them get into this clinical trial. And now we're look at what we're sitting here talking about. We're actually sitting here talking about a drug that targets IDH1 and IDH2, both of those markers. It targets both of them. So we are literally witnessing history and evolution of treatment of gliomas, low-grade gliomas as well. So it's super exciting. So a question came in, and it's the question for a lot of patients who are diagnosed with a low-grade glioma. This is from a caregiver from Wisconsin. If your current treatment plan for a low-grade glioma over the last 8 years has been to wait and watch with regular MRI scans, is there anything else I can do to reduce the chances of recurrence or be better prepared for it?
Yeah.
This is where we're at today, and we might have.
Very good question. Very good question. And that actually shows a couple of points, that there are these subgroup of low-grade glioma patients who could just wait for a long time and still not get, have tumor growth several years. The second question of what can I do? You could potentially use things like IDH inhibitor when that gets approved. Although the study said 5 years, these patients who were enrolled in the study were between 1 to 5 years from surgery. These are arbitrary numbers. When we do IRIGHT trials too, we all have to have these numbers. There's no science most of the times on these numbers, on why did we pick 5 years? Why didn't we pick 10 years? And those kind of questions keep coming up after these trials are open and enroll patients. So talk to your physician. When this drug gets approved, is this a good drug for you? What are the pros and cons? And I think this is it seems like at least you're eligible if you have IDH mutation, and that is a way to reduce the chances of tumor growth, and that's exactly what this trial was looking. Now that I can see chat, I see a couple other questions. I don't know, you have a couple minutes. I can answer these if you
Go ahead, please.
Can the tumor lose IDH mutation, i.e. become GBM? That's a very, very good question. Generally, the answer is no. IDH mutation is a very early mutation that happens in the tumor, and subsequent tumor growth, we have seen that IDH mutation continues. Now, there might be other mutations that add on to that. That can happen. And also, there's a big question of would currently available IDH inhibitor be as effective in high-grade patients? That's a good question to ask, and there's no data yet to suggest one way or the other. And I believe there are going to be studies in high-grade IDH mutant tumors. To be honest, the WHO classification in 2021 clearly mentions that patients with IDH mutation, even if they have grade 4 characteristics, they are not called glioblastoma, they are called astrocytoma grade 4. So we all recognize these patients do better than glioblastoma patients.
So super cool. I wonder if they also meant to ask a question, which is a little more generic, which, you know, that some low-grade gliomas do progress and become more cancerous. They do turn into GBMs. So when we think about the knowledge, the scientific knowledge that we now know, and we think about the possibility of a drug that the idea is to stop that from happening, it's just an incredible game changer for the patient brain tumor population, as well as healthcare providers. I mean, I think about you and all of our healthcare providers who are serving this patient population, and they will finally have actually something that they can provide.
That's so true. But then, the other point is it makes the discussion very complicated. And it's also the reason why I think most of the patients who are diagnosed, especially with low-grade glioma, should seek out a neuro-oncologist and a team which has expertise in taking care of patients with low-grade glioma. I think it's really important. They should reach out to patient advocacy groups like yours to find the right team that can take care and have this nuanced discussion. Because in the past, it's like, okay, let's go ahead and do radiation for all patients. Now it's really nuanced. And a lot of my patients, even my patients who come to an academic center, I send them to get some second opinion if they really want to. It's really important for them to be comfortable with what we're offering and what we're discussing. And this discussion is getting, more complex, and rightly so. For patients, we have more options.
It's an exciting time. I can say this, and I'm very excited about this. The End Brain Cancer Initiative actually will be working with the FDA a little down the road in order to help with FDA approval related to vorasidenib. We'll be able to supply patients to speak to the FDA, as well as, of course, we are able to testify to the FDA and uniquely convey the need for this approval for this patient population. And not only for this patient population, but truthfully, it's moving science vastly forward. So it's an exciting time. So Dr. Avgeropoulos, and I may have just messed that up. I just will call you Nick. He is a medical neuro-oncologist with over 25 years of experience focusing on clinical practice and translational research. His fellowship after neurology residence include the Medical University of South Carolina in neuroimmunology, Yale New Haven Hospital neuropathology, and Massachusetts General Hospital in medical neuro-oncology, all focusing on different aspects of brain and spine tumor management. He most recently joined Novocure as their global therapeutic area lead for CNS cancer. And his talk today is actually very exciting. He is going to be talking about living with GBM and TT fields. So Dr. A, you have the floor.
I'm grateful, and I'm grateful, of course, for the invitation. I'm always grateful to really be reminded, even after 30 years, of what this is all about, which are the questions, and finding solutions. So with that, I will share this presentation, and I'll have a I'm sorry, Dellann, did you have any specific comment or question, or you were just prepared? I saw you rustling papers, so I'll go ahead. Okay,
I was just reviewing some of the other questions that came in on people's registration forms. So you please present. I'm eager to hear.
I'm on it. And I want to assure your audience and everybody joining us, I'm not in a rush through the presentation. I'm really grateful for that. And whatever it takes, because this takes precedence. So for my presentation, really, it's an introduction to those of whom are unfamiliar with Tumor Treating Fields, the device and the therapy, and also to drill down onto some of the impact that Tumor Treating Fields has had in the space of glioblastoma, and more recently, lung cancer getting an approval. So there's another indication, and that's right. And yet, even more, there was a recent press release about further treatment advances there. So with that, I'm going to focus on glioblastoma, of course, which is the purpose of this. My, please feel free to call me Nick or Dr. Nick, as I was in the clinics for 25 or 30 years. And so, again, let's move on. So here is the Tumor Treating Fields, or TT fields. Some may be fully aware or users of it, but I want to start out by talking a little bit about the timeline of this. You know, we're talking about 25 years itself in the making, starting from the laboratory analyses, and then from 2006, so almost 18 or 20 years ago, the EF11, which was used in recurrent or progressive glioblastoma, was evaluated as a proof of concept. And when compared against the best therapy at the time as a single intervention, in that study, there was no disadvantage one way or another, except to say the quality of life was better and maintained for longer. And so, with respect to the ongoing evolution of that, we see in the 2009 timeframe, the pivotal study, so-called EF14, had a randomization. So before that, there was the chemoradiation with temozolomide, and then subsequently the 6 cycles of chemotherapy, most of the time called either the STUP or European regimen. And then on top of that would be, in 2 out of 3 arms, added Tumor Treating Fields. And so in that study, and along the way that unfolded over the course of over 5 years in terms of getting its FDA approval, we noted that there was a definite improvement in the progression-free survival, a definite improvement in median overall survival, and also, quite importantly, there was a 160% improvement in 5-year survivorship. So that is, a message that certainly resonates with many. And honestly, that's the one that just keeps coming back, and in the best way. So, we keep setting new bars, and I want those bars to be way over our heads so we can jump for them and get past them. So, as we move on after the FDA, this becomes available in Japan, in Europe, in varying countries under varying capacities. And then there were the other indications, which I mentioned, which was the mesothelioma was one of them. And the other, although the LUNAR study did not yet end up in any kind of approval, we anticipate that that's going to be out very soon, we hope, for patients. But yet that study met its primary endpoint, and we're very excited about it. And it was presented in a major conference last year. So Novocure in general is dedicated, particularly focusing on the most difficult and aggressive forms of cancer. That's our space. We're not, looking to make a more efficient anti-cholesterol medicine or blood pressure medicine. We're talking about, running, as the saying is, it's like, well, when there's danger, do you run towards it or do you run away from it? Sometimes, honestly, you have to run. As they say, there's this fight or flight, actually, you know, from a standpoint of observation, it usually is freeze, flight, and then fight when you have to. Here, we do the opposite. So we run into it because that's where we got to go. And if not us, if not now, when and who. So, and that goes for all of us, I think, on the call. And so with respect to that, I've covered a lot of those. And again, I think that the main message here is that this is not a new therapy. This is an established, approved therapy that is a standard of care. And in fact, when you look in the NCCN guidelines, it's the only preferred Category 1 recommended treatment for glioblastoma. There are Category 1 recommendations for the Stoop European protocol, but those are standard Category 1. So that is a testament, at least in the US market, that there is that preferred designation. So what is this, you know, and where's the mystery in all of this? And so, you know, as I was going through training, one of the key questions is, you know, what can we use for maintenance therapy? And to give you an example of some of those, we used to prescribe high-dose tamoxifen because there was some rationale in that very high-dose tamoxifen that maybe it repressed some aspects of tumor growth. And what we ended up doing was we ended up giving people blood clots, because that really was, at that high a dose, that was one of the main adverse events. And we didn't find that there was any kind of equitable trade-off in terms of benefit. Then we tried things like Accutane, which, you know, was found in a phase 2 study to help. But then when you give it at high doses, it ends up actually increasing intracranial pressure and becoming quite problematic in many patients. So here, as opposed to those therapies, here you actually, you know, marry that notion of a continuous therapy, which is the, you know, the maintenance idea, but you marry it with an active treatment. So this is not, you know, some wet blanket that's kind of keeping things under wraps. This is an active antimitotic therapy that is destroying tumor cells real time. How does it do that? The device, you can see depicted on the right of the screen, has two opposite, almost perpendicular placed arrays. Each array has 9 ceramic leads connected by flexible, circuit. And so it alternates. And when it does that, it actually goes and it disrupts cell division, because cells, if you know anything about polar versus non-polar, namely some are very magnetically susceptible, and when one cell a cancer cell tries to divide into 2, it uses a scaffolding of building blocks to try to get that DNA material to separate. But if that scaffolding is disrupted by these low intensity, intermediate frequency electrical fields, well, then it can end up disrupting that process. And the angle at which that field is directed is important as well. So getting it from 2 angles in a sweeping fashion has been proven clinically effective. So here, this picture's a lot. You know, I wish I could show you a little bit different one, but it's all of this. Let me kind of drill it down into, you know, the business end. So the stuff that is ancillary or auxiliary equipment for, you know, charging batteries, keeping it plugged in, and things like that when in a stationary way. Here's the battery charger. Here's the portable batteries that can then be loaded right here into the unit. Here's some portable battery case if you need an auxiliary. here's the power supply that plugs in ultimately to the device. But and this is one of the carrying cases. So where's the actual kind of thing that a person would be wearing every day? So it's this binocular-sized 3-pound device. It is attached to these transducer arrays through the connection cable, and then it's usually kept in a ventilated backpack. And I mean, that's the size of it. I'm not minimizing what it is. It's a commitment and a behavioral modification, no question about it. But honestly, it's not as kind of overwhelming as this slide may depict. That's just a very inclusive photo. So tumor treating fields integrating in patient lifestyles. Obviously, this is where the rubber hits the road, because it's like a medicine. If a medicine is great, but if a person can't tolerate it, or if they're always vomiting from it or something like that, it doesn't do any good. So with respect to the tumor treating field device, it's totally key from a social aspect, from a physical functioning aspect. But of course, the stakes could not be higher. It's a clinically approved therapy. So really, the oncology aspect usually is the risk-benefit ratio tipping the scales. And so it's portable, and you can see on the right-hand side, we have somebody wearing the backpack with his family, and the other patient ambassadors depicted. And so this is something that can integrate. And usually the steepest portion of it is kind of like, in a way, it's kind of like losing weight. I'm going to kind of crunch into, a little bit, maybe sometimes socially uncomfortable thing to talk about. So as a neurologist, way back in the day, decades ago, somebody would come in with low back pain. And so, you can do, non-invasive things, and stuff like this. But ultimately, if the person is, 370 pounds, the amount of torque that's on the back, or even 280 pounds, whatever it is, that's the first and best therapy. So how do you tell somebody, that they need to lose weight? Well, these, you could just pick up any magazine, and there's typically a lose 20 pounds quickly and a 5-layer, chocolate cake on the same cover. I mean, it's difficult to process many of those. But at the same time, what has to happen? There really truly needs to be a behavioral modification. Even if there's an extreme intervention like a stomach stapling or liposuction or something like this, honestly, in the end, it needs to be behavioral modification, that or smoking cessation or anything like that. So here, there is a learning curve, and so we're talking about integrating this device over a long period of time. Because the way that the study was performed, that even after a first imaging progression, the recommendation and the protocol states stay on the device. This is, the tortoise and the hare. This is the tortoise. This isn't like a bolus of Avastin, for instance, where there may be very quick appearances of tumor control. This is one that takes a while, and that's why the earlier one starts it right after chemoradiation, the duration being the longest, the usage rates being longest. That's when we see the most optimal results that really tip the scales in the favor of the patient. So what about the actual lifestyle integration? Well, there are, as you see, patients can elect to wear hats, usually lightweight scarves, even wigs with, a mesh that's not too tight, being mindful not to get it wet or to get overheated per se. Skin skincare is really the name of the game here, because these leads have to be exchanged every couple, 3 days so that the skin can breathe, so that the head can be shaved clean instead of stubble, because then the device won't be adherent. We have to be mindful of skin integrity, because the leads are almost certainly going to be over an area that's been irradiated or operated or both. And so we want to be absolutely mindful of that. And we have some very effective algorithms for doing so. And sometimes we give people a little holiday and say, hey, listen, this is a long game, which is a great thing to talk about when you're talking about, control of a malignant tumor. You're like, hang on, don't lose hope, don't lose confidence. And so, there are other modifications which we went over, the sleeve bag, the 5-in-1 bag, and so on and so forth. And so, ultimately the key is going to be the social support that a person has, the infrastructure, the social infrastructure that can help a patient, that can accept a patient's new norm, so to speak, normalizing something that may be different. So for example, if a person, let's say in another disease state, like a woman's cancer who gets IV chemo, that woman will certainly go bald. And then the stigmatic part was bald is beautiful. I mean, some of those slogans that came up, which I loved. And in this case, it's not so much that, okay, a person goes bald, it's that it's pattern alopecia where the radiation went. It's self-induced, and then there's a device certainly in that capacity. And that, self-awareness and self-perception is something that, we try our very best to get a person to own. And I know that works best when they have a strong family support. And it really is, it's worth it in the sense that the numbers, the numbers don't lie. The imaging doesn't lie, and patients have had absolutely fantastic experiences overall. But of course, one would really be misgiven to say, okay, categorically, everybody's going to have the same experience, obviously. So one thing that I'll underscore here is the continuous exposure of this. So systemic treatment is, here's one cycle, here's another cycle. And then radiation treatment, well, you give a fraction, you wait, you give another fraction, so on and so forth. Here, it's really a continuous exposure over time. You may take, we recommend 75, well, not only recommend, that's what the clinical trial has demonstrated, 75% and greater usage rates, even in decile, every 10% that goes up. Patients have improvement that's almost linearly related. And in fact, when patients have had 90% ability to stay on the device, the 5-year survivorships went up to 28%. So, I would challenge, and I wish somebody would answer that I'm wrong. I would challenge anybody to show statistically significant study of this magnitude that has that kind of outcome. And so this is, again, as a neuro-oncologist, this is what I'm going for. Obviously, quality of life is at the core. Well, I want it all for my patients. I want quality and quantity hand in hand. And so when we have numbers like this that are statistically significant, that's not a fluke. So with that, hopefully, hopeful and encouraging ending, I'll pause and complete this presentation to take questions. And Dellann, I'll turn it to you for moderation.
Thank you so much, Dr. Nick. So I have a question related to Optune Geo, so TT fields. I think it's important, if you could address that, you know, when patients are using the Optune Geo device, you know, Novacure provides people that are out and about that are there to help support and train how to put on the device. Is that correct?
Yes, it sure is.
Can
There's
you
the
talk-
device support specialists.
Can you talk more about their role and how they are helping patients wear this treatment option?
My pleasure. Thank you for that. You know, the part and parcel of this is making it work at home. This is an ambulatory therapy. It's not something that you go in and get a dose. And so the device support specialist initially comes in and reinforces and takes sometimes hours to sit through and do almost a home safety evaluation per se, to say, okay, what's happening here? Where are you going to have this device to charge it? What's the safest way to do it? How do you prepare your skin? How do you troubleshoot if you have any issues? How do we communicate the device usage data to your physician so that they know how things have been going and can best counsel you? How do we kind of make this as easy for you as possible, and how can we provide that? So these are folks, of course, at the patients and the caregivers scheduling will come out for regular or routine check-ins, for as needed check-ins to make sure that everything is going well with the device, and to make sure even things like hardware or leads or things like that are absolutely kept up to date. So those that's an integral part of our interface. And to conclude that remark, here is a device that has its own research development, production facility, medical component, and then home care piece. I mean, this is not a pharmaceutical company that manufactures its drug and then sends it. There's nothing wrong with that. I don't, belittle that in any way, shape, or form. This is the strength of this.
As part of the treatment plan for Optune Geo TT fields, sleeping in the device?
Yes. Yeah. And so I kind of think of that as, banking hours. If you're looking for a 75% aggregate exposure, I strongly endorse that patients will learn to sleep as comfortably as possible with them, because there you go. There's, let's say, 8 hours out of the day already. And so people sometimes they like to take a break every day. Other people will bank and just run, through a couple of days. And then when a special event comes, or getting out for dinner and letting the skin breathe, and, we're going to a special event, and if that's not the time to wear the device and go out to church, to, a wedding, or to a dinner where, it's just, look, I'm taking a break. You can still bank well over 75% when being tactical about it. So those sleep hours really add up.
Very interesting, right? Hey, how much does the battery pack weigh in the backpack?
So the whole device, I think, about 3 pounds. I think most of the weight of that is in the battery. And then the backpack is, I don't want to mislead you, but it's probably half a pound or something. It's very light. You bring up a very intriguing point, is that this is the only anti-cancer therapy that, like your iPhone, can be upgraded. You used to have a boom box, then it ended up being an iPod. Now, I've got a microchip, one half the size of my pinky nail. So more to come. No promises, but that's the direction. Yeah.
Okay, so I have one last question, and I'm looking, and I don't see any questions in the chat yet, but as you know, we, of course, work with and talk to patients every single day who are using the Optune Geo device. Does Novacure, I mean, I know you have, I forget what you call it, but it's your support group. You know, people can email, they can call, but on a regular basis, is Novacure addressing, you know, the skin, I'm just going to call it an issue, right? We hear from patients, not every patient at all, you know, that sometimes the arrays, you know, can get hot, or they can cause a rash or itching, things like that, which is, you know, we hear it a lot. I know you hear it a lot. Is Novacure considering, as part of their support when they're teaching and training people how to utilize this device, some kind of salve or something to also utilize for comfort?
Thank you, Dellann. You know, again, a very insightful question. I kind of think of it like a car wheel. I saw another commercial where it says, well, it's the only part of the car that touches the ground. So the arrays are the only part really effectively that touch the patient, obviously, when you carry it. And so, yes, it's a principal and primary focus of Novacure, and there's an algorithm, and there are algorithms for skincare that we not only counsel patients, but also nurse practitioners, nurses, physicians to go through that. And sometimes, you know, we do have to have a dermatology assessment or something like that to really help with a high power steroid. But yes, staying ahead of it makes people enables patients to use the device more, which means statistically better results. So yes, it's a principal consideration.
Awesome. I'm glad to hear that. That's what that's what we're hearing a lot, right? So in the very beginning, you know, we would hear, well, I don't want to wear it because what it looks like, and, you know, and then we would talk about that. And then we talk about all the different ways you can wear the device with what you talked about, a scarf or a hat or even a wig, et cetera, you know, and it took a while and years to address that, but it seems like that's addressed. And so what sort of seems to be coming up is what I just asked about, is it's that other part. And so I'm glad that Novacure is considering maybe how to incorporate that into part of their training.
Indeed. And, you know, we have just in the past, let's say, year or so, have actually included in our global medical cross-functional team. Sorry for all of those, you know, terms, but one pillar to skincare from soup to nuts. So that's from looking at the adhesive, to looking at the treatment, to working with dermatologists to improve that. I mean, everything, including literature that's educational and promoting understanding to healthcare providers, in addition, of course, to the patients, which is the principal focus. Absolutely.
That's fantastic. So it's very important for everyone to understand that the Optune Geo device is actually the very first device, as we talk about GBM, to be approved by the FDA. So in many ways, not only is Novacure providing another treatment option, which is FDA approved, which is part of standard of care, but, you know, they're leading the way for additional companies and biotech companies to come up with different devices to also be considered as treatment options, which is incredibly exciting. You know, as we know, we need lots of treatment options for brain tumors and brain cancer and metastasized disease, by the way.
Indeed.
So thank you. Thanks, Nick, so much for joining us today. Really appreciate it.
Dellann, it's always a pleasure, and I look forward to seeing you soon, maybe at ASCO.
You'll see Sean from my team at ASCO. I have a personal commitment this year that I cannot be there, but I will
That's
definitely
fine.
I'll definitely see you in November, if not
That's
before.
perfect.
If
If
not
not
before.
before.
Yeah.
If not before. Thank you,
Absolutely.
guys.
So Nick's information is up on the screen. If you have any other questions about the Optune Geo device or TT fields and how they work or how to access or any other questions, feel free to get a hold of Nick. That would be great. Thanks so much.
Thank you again, and thank you to your audience. And
Absolutely. And thank you to Novacure, by the way, for supporting our National Hope Award, you know, that patient education, awareness, and outreach initiative that we started off today with. Thank you. It's really important to us.
our pleasure. Okay, talk to you.
Ciao. We have Stephanie Key, and she is the commercial clinical director at ZAP Surgical Systems. And she is working to drive the successful implementation of the ZAP-X system across North and South America. Stephanie started her career in radiation oncology. She previously worked as the Director of Clinical Applications and Director of Clinical Marketing at Accuray Inc. Her clinical experience and drive to improve the lives of cancer patients have propelled her forward in her career and what ultimately brought her to ZAP Surgical. She hopes to bring this revolutionary technology to as many patients as possible. And that's why we asked Stephanie to join us today. You know, we're talking about treatment options and the evolution of treatment options for gliomas, high, low-grade gliomas, also metastasized disease. And this is a particular system that has evolved as well. And we're super excited to learn more about this radiosurgery option. Stephanie, you have the floor.
Great. Thank you so much.
Thank you.
Thank you, Dellann, and thank you, End Brain Cancer Initiative, for having me today. I'm excited to speak with you, and I'm going to be talking about what she mentioned before, the ZAP-X gyroscopic radiosurgery system. To get started, I wanted to kind of create a foundation of stereotactic radiosurgery, what it is, and how it differs to traditional radiation therapy. So when we talk about stereotactic radiosurgery, it truly is an alternative to surgery for many primary and metastatic brain tumors. It also has the ability to treat functional disease and some vascular diseases. An important differentiator is that it is completely non-invasive. Outcomes from treatment of radiosurgery can be either equivalent or superior in certain instances than traditional surgery. And it's typically delivered in a brief outpatient visit over 1 to 5 treatments. This differs specifically to traditional radiation therapy, which is generally delivered in 10 to 30, we call them fractions. So we're condensing that treatment down into 1 to 5 and delivering higher doses, but using pinpoint accuracy and pinpoint beams. So when you look at the image on the left-hand side of the screen, the target is this yellow region, and each one of these gold lines is a small beam that's focused on the target, which is adjacent to the brainstem, which is contoured here to give you some idea of reference to the location of the target structure. So when we look at comparisons to radiosurgery and traditional surgeries, we have some published data that show that patients experience less side effects. And if you look at the graph on the right-hand side of the screen, this was a study comparing radiosurgery to traditional microsurgery for acoustic neuroma. And the scale in the bar graph shows that for gamma knife radiosurgery, which is a different type but a similar concept as ZAP-X, patients saw improved hearing for the acoustic neuroma. The most common side effect for surgery for acoustic neuroma is hearing loss. So some patients saw improved, others saw stable hearing as compared to traditional surgery. Some people saw deterioration, but for the most part, when you look at total hearing loss, there's a significant reduction in total hearing loss as compared to traditional surgery. And when you look at the experience for the patient, their time away from work is significantly less. So the time to recuperate and recover from surgery was reduced from an average of 120 days to an average of 7 days that they were back at work, which kind of sets us up to what we're doing and what we're trying to accomplish. We're trying to create a non-invasive procedure that gets you back to doing what you love to do sooner rather than later. So this video shows the device itself. It was invented, and our founder and CEO is John Adler, who's well known as a neurosurgeon at Stanford University. He's also well known as the inventor of the CyberKnife system. So he took the best of the CyberKnife system and the best of the Gamma Knife system and created something entirely new. So the system is actually self-shielded. When we talk about radiation, we have to protect the people around the system. Anyone who could be exposed to radiation, we need to keep that to a minimum. So the fact that this system is self-shielded means that it can be placed in locations that were not possible before. And your treatment team is going to be generally right next to you. So this mechanism is how we shape the beam. So this is what creates the radiation. This is what shapes the radiation. So we're using different sizes of very small pencil type beams to treat tumors inside the patient's brain. A procedure is started with imaging. So we use KV or X-ray imaging at the patient in the treatment position, and we register that to their CT that was created prior to delivery. We use that to make sure we are in the most accurate position for treatment delivery. So when we register the daily image with the CT image, we're able to adjust the couch that the patient's lying on to make sure that they are accurately positioned for treatment delivery. This is a gimbaled gantry design. This is where the gyroscopic aspect comes into play. So there's 2 gantries that rotate in conjunction that give us thousands of potential beam angles around the patient's skull. It's important that these are considered to be non-coplanar. Every aspect in the design of this system was intended to reduce unnecessary dose to the patient, to the normal brain, to the normal critical structures such as the optic nerves, brain stem, optic chiasm. And then we also want to reduce unnecessary dose outside of the patient's head. So you'll see in the video here the gantry rotating to deliver beam by beam to the tumor that's located inside the patient's brain. We're also measuring the exit dose of every single beam to ensure that what we planned to deliver to the patient is what we actually deliver to the patient. These are high doses of radiation delivered in 1 to 5 fractions. So it's critical that we make no errors. And that detector was added to ensure that we meet the expectation from the planning system. So I mentioned that your treatment team would be adjacent to the system. So your physician, physicist, radiation therapist are truly adjacent to the device right next to you during a treatment delivery. So the indications generally treated with radiosurgery are brain mets primarily, and then there's some benign disease like meningioma. Glioblastomas are treated. Then another benign acoustic neuroma. Trigeminal neuralgia is a functional disease, not cancerous, but we also, as I mentioned earlier, treat vascular diseases and other miscellaneous benign tumors. We're also able to treat some tumors of the spine. But this is a system in a hospital in Munich, Germany. I mentioned that it's self-shielded, and this kind of gives the hospital some advantages because it opens up their ability to place the system. Generally, radiation oncology departments are in the basement. So the patient goes down into the basement. They have vaults that are made up of 6 feet of concrete and probably some additional lead shielding. The patient walks down a vault maze, and there's a heavy door. And all of this is there to protect personnel and others from radiation exposure. Because the ZAP system is self-shielded, we can put windows in the room. From a patient experience perspective, it just is a little bit more comforting to walk into a room with natural light. But obviously, these windows would be closed during treatment delivery to protect privacy. But it's truly precise. I mean, Dr. Adler's vision here is that we have a system that gives best in class, giving a physician a tool that is a true alternative to surgery. From a patient comfort perspective, our immobilization is a thermoplastic mask. You may have seen these before or had one made on you in the past, but generally speaking, they're more comfortable than the traditional forms of immobilization, which is an invasive frame. And then last, because it's non-invasive, there's less risk of secondary infections, and it also helps to reduce or eliminate recovery time. From a patient perspective, and this is a picture of the very first patient that was ever treated on the ZAP system at Phoenix at the Perreault Neurological Institute. This is Dr. Barranco, the neurosurgeon, the chief neurosurgeon on the project. But from a patient perspective, it's a simple outpatient procedure. You can see he came in with his family. He's dressed in street clothes. He's going to leave in street clothes. There's minimal discomfort. Again, we use a mask-based immobilization, and you lie on a table that's padded. If there's any point during a procedure that you need a break or your back hurts, the procedure can simply be paused, and then you go back in for the final or to complete the treatment. And most patients return to normal activity the same day as their procedure. So in the data, the journal article I showed earlier, it was 7 days to return to work, but most patients are actually going back to regular activities the day that they're treated. So a traditional process of seeing your physician to getting treatment. Once you've consulted with your radiation oncologist or neurosurgeon, and they've determined that radiosurgery is a good option for you, you'll have an immobilization mask made. And you can see that here in the first image. So these are specific to each patient. Once you've had your mask made, you'll go for CT, and then you'll have an MR image taken. The MR image series is fused to the CT, and that fused image data set helps the physician define where your tumors are. A lot of people ask us, because it's a closed system, what the experience is for the patient. And it's truly quite large inside, and it's lit, well lit and ventilated. And it's much larger than an MR, much quieter than an MR. So from a patient experience perspective, you're not going to feel as enclosed as you do in a traditional MR. And it's also quiet. And we have a speaker system, so they can actually play some, calming music during the treatment delivery. But once the CT and MR have been fused and your physicians have defined the tumor volume or volumes that are to be treated, a treatment plan is generated. And the treatment plan, you'll see here in the third image, is a physicist or a dosimetrist determining where the beams should come from in order to avoid nearby critical structures, like the brainstem here or the cochlea here. So the cochlea affects our hearing, the brainstem affects many functions of the human body. So we want to ensure that that any dose to the brainstem is as low as reasonably achievable. Once the plan is generated and the physician has signed off and approved on the dose distribution and the beam arrangement, then the patient is ready for treatment delivery. So you saw the treatment delivery procedure in the video. It's pretty simple. Once the procedure is over, you return home or wherever you live, and once all treatments have been completed, you'll be followed up with your radiation oncologist and neurosurgeon. So I wanted to show a quick video of a patient that was treated recently in the Hackensack Meridian Network in New Jersey. It's a really nice example of a patient seeing some benefits from radiosurgery. And this hospital was added to our program towards the end of last year. They started treating patients in October 2023, and they have increased their patient volume by 300%. So it's really a kind of a testament to them and their program to see how they've scaled.
I like to play bocce. I was playing softball up until just a couple of years ago. I'm president of the Italian American Club in Greenbrier. I'm always organizing, getting parties going, different types of cultural events and so forth. Keeps me busy quite a bit. I had double vision. I went to an eye doctor, and the eye doctor suggested I have an MRI done. When it came back with the results of the MRI, it showed that I had a benign brain tumor. And they told me that it was probably even too large for surgery, that they didn't want to mess with it. So when I met with Dr. Chen, he explained to me how this new ZapX was going to be maybe 3 to 5 treatments. The first thing, as he explained to me, is that the procedure itself should stop the tumor from growing, causing any more damage or anything like that. The hope is that it will start to shrink and my vision will come back, so I don't have to wear special glasses now that have prism in them to correct my vision for me. I asked them where to sign up.
It is the first day, the treatment for Anthony. He had a series of planning done, series of scanning and MRI done, and this is the crucial for this unique treatment. We can see him, we can hear him, and he can hear us too. And he's pretty much in there just waiting for treatment.
We're doing one of our first ZapX treatments in New Jersey, and one of the first in the country. We can do non-invasive neurosurgery with this machine and treat things like brain tumors, brain metastasis, and treat them in a non-invasive way to benefit the patient the most. It's a big deal. You know, we're certainly the first in the world to combine ZapX with the Synaptive MRI machine. We're also one of the first in the country to have the ZapX machine here available to our patients.
There's a wide area that's all the tumor, and this tumor has pushing on the optic nerve and chiasm, also brainstem. And this is now, we already seen the tumor got smaller, less plump, and also the structure inside, such as this vessel you're already showing, which is not seen before. So that's why one of the reasons that his vision is improving. This is already good, and we expect this continue to shrink even up to 2 years, and maybe even go beyond that. And this treatment is so convenient. There's no invasive procedure. A lot more patients now can be benefit from this is one of the kind state-of-the-art treatments.
Thank you for allowing me to play that video. I'm going to end my presentation here. If you have any questions after this webinar today, you can feel free to reach out to either me or info@zapsurgical.com. Radiosurgery is a great option if it works and is directed by your physician. And thank you for your attention.
Thank you, Stephanie, so very much. So info@zapsurgical.com, or we also can put your information back on the screen. I have a question related to GBM.
Yeah.
What's the biggest size of the tumor that the ZapX can be used to treat it?
So the largest GBM we've treated to date is 60 cc's.
Which is like what?
Which would be about probably 5 cm by 5 cm.
Okay.
So it's not, pardon?
Sorry, does it matter what shape?
So no, it doesn't matter. The shape is actually, the beauty of being able to shape our beams into small pencil type sizes allows us to use so many of them that we're able to kind of dose paint along the irregular surface of a target volume. We've also treated recurrent GBMs, and we've treated the cavity post-surgery when a GBM has been removed.
And I know why, but can you explain to everybody why?
Why that we treat the post-surgical bed? Okay, so generally we will treat the post-surgical bed if the surgeon is not 100% sure that he was able to get all of the margins. So there could still be some microscopic disease in the brain that they want to kill with radiation, or they want to kill those cells with radiation to make sure that they have as clean of a margin as possible.
That's cool. Okay, so say I'm a patient in the United States. Where is this machine, ZapX, where is it available?
So in the United States, we have 6 centers currently. We started treating the patient you saw in the presentation was treated in November of 2019. And since then, we have 26 systems globally. In the US, we have, as I mentioned, the Perreault was the original site. There's Littleton, Colorado. It is Centura Health. Neuro One is the neurosurgery group there. We have most recently the Miami Cancer Institute in Miami. We have Larkin Hospital in Miami, which is driven by a neurosurgeon there. We have a system in the Georgetown network in suburban Maryland. They wanted to bring radiosurgery to the community because they had a lot of patients that didn't want to drive into downtown DC for, just for 5 days or 5 fractions. And then we have the Hackensack system in New Jersey. And we are installing next year Westchester Medical. And so Dr. Hanft will be a user here, hopefully within the next year. And then another system in a private neurosurgery group in upstate New York, Dr. Sethi.
Stephanie, how important is it for patients to come forward to the healthcare providers and to say, hey, look, I just learned about ZapX surgical, and boy, that is really something I'm really interested in getting, how do we start, creating more access, right?
Right.
So ideally, ideally this would be available anywhere that we have CyberKnife and Gamma Knife and, all the regular, and even maybe proton beam therapy, right? All the regular other sources of radiation.
Yes. So patient education is critical, like you said, and initiatives like yours are the foundation for making sure patients know what's available to them. It may not be available in your regional area, but you've heard of it. And it shows that you have an expectation that, okay, precision matters to me. There are things that are going to be more precise, like you said, the Gamma Knife and the CyberKnife. When you're talking about dedicated radiosurgery tools, these are the 3 that really make up that type of device. Proton is an important addition to the space. Proton is extremely expensive and difficult for many patients to be authorized by insurance. The benefit of proton primarily 100% pediatrics. 100% pediatrics, yes, they're going to see major benefits dosimetrically. But with systems like ZapX and the intentional design to reduce unnecessary dose to the normal brain in nearby critical structures, this is something that we see as a pediatric platform as we move into the future. We just need more data. We're earlier on in our life cycle. I hope that answered the question.
Yeah, absolutely. We have a question that came up. How does ZapX compare? You probably just explained it, to proton therapy. And then this person's concerns would be the exit radiation. Can you address that, please?
So when you look at the dose distributions between Zap and proton, they're going to look, interestingly enough, pretty similar. The proton exit dose will be less, but the magnitude of difference is under study to determine whether or not it's clinically relevant in many disease applications.
Okay, so here's a question. With the ZapX machine, can one's brain tumor or brain stem be radiated more than once?
Yes, and that's the intention. That's why we use a lower energy, we use smaller beams, because we will not reach the tolerance dose of the normal brain on the first round of treatment. So if a patient experienced additional METs or additional METs were identified 3 months, 6 months later, they should be able to come back for treatment multiple times.
Okay,
And I
that's
wanted to mention that Dr. Chen, who was the physician that spoke in the last video, they're actually doing a dosimetric comparison of ZAP against gamma knife and proton specifically. So we'll have published data here in the next year.
That's fantastic. So what I just heard you also say, you know, yes, ZAP-X is used initially, but it's also used basically as a maintenance treatment.
That's true. If you're being treated for brain mets, yes. Or you could come in with a primary brain tumor and later on experience mets. You should be able to be managed using radiosurgery with ZAP-X.
So the idea is essentially killing all of those other microscopic cancer cells, but also, you know, blowing up, basically. That's how I explain it, the brain tumor.
Right. We want to kill all of the cells associated with tumor and protect all of the cells that are healthy and viable.
Okay, so for all of the patients and family members and caregivers that are listening, now you know about ZAP-X. Please take this information to your healthcare providers and simply let them know you learned about it, who you learned about it from, but also say, hey, we'd really like your institution to consider in this investment to better treat your patients. The reason I ask that is because that's advocacy, and it is patients speaking, and it is patients speaking that does change things. Because hospitals, institutions know full well you can go somewhere else for your treatment, and they prefer to keep you there. And your voice really does mean a lot. So that is one way to advocate for more and more and more of these machines, not only in the US, but globally. So that's really, really exciting. Thanks, Stephanie, so much for sharing.
Thank you. Thank you so much, Dellann. It was a pleasure.
Thank you as always. We'll see you.
Bye.
We have next up, and this is our last presenter of the day, is our very own Shreya Prakash. She is our clinical research coordinator and our patient navigator. She works Monday through Friday, 9 to 5 Pacific time. And you see on the screen her contact information. She's going to talk to us today about something that we are utilizing here within the In Brain Cancer Initiative to help provide patients with brain tumors, brain cancer, and metastasized disease to the brain more of a personalized precision medicine approach to help identify treatment options, additional treatment options for you. So Shreya, you have the floor.
Thank you, Dellann, for the introduction. Okay, so I will be talking about XQs today. As I was going through the registration forms, I know a few people wanted to know more about artificial intelligence and their use in narrowing down clinical trials or getting treatment plans for to help them with treatment plans. So XQs is one of those platforms. So XQs is an advanced online tool designed to help patients with cancer, and this includes brain cancer, metastatic brain cancer, and this so it helps to find most effective treatments, and then it personalizes it for the patient-specific condition. So how this works is that first, when you sign up, you have to create an account on XQS platform, and once you create an account, the platform then gathers detailed information about your medical history, your current conditions, and previous treatments by reviewing your medical records, test results, and other documents. So for this, you have to upload your own medical records, your test results, and other documents to the platform after you have created the account. You can either do that you can do that on your own, or you could just give XQS permission to maybe retrieve it from MyChart or Epic. So once all these medical records are uploaded into your account, then the analysis and recommendations part starts. So XQS then uses artificial intelligence to analyze your information, and it compares it to the large database of cancer cases they have. And then it suggests treatments to identify effective options for your condition. So when it says it compares it to the large database, it means they have other cancer patients who have accounts, who have their medical records on there, and it will try to find someone who may have had a similar condition to yours, and they will see what treatments did this patient use in the past and were they effective. If they were effective, then the AI will suggest those treatments for you. So you could bring it up to your doctor and maybe discuss it with your doctor to see if that treatment is a viable option for you. So then it creates a personalized treatment plan once it has done the analysis and recommendations. It will suggest clinical trials or specific medications that are out there. It's good to note that XQS is constantly updating its platform, so it is up to date with the new treatments that are upcoming, new clinical trials that are upcoming for cancer patients. Next is, so EBCI has a provider portal within the platform. XQS has two different ways of maybe suggesting treatment plans to the patients. One is the provider portal, one is the X-Inform portal, which I mentioned, which is what patients has access to. So X-Inform is specifically for patients, and provider portal is for doctors and for organizations. Now there's two ways you could create this X-Inform account, sorry. And one, you can create it on your own, and I will show you in the next slide where to go to create on your own, or EBCI, and I can help you in creating this account. After you have registered, you will be signing a consent form. This is the consent form that grants XQS permission to access the medical records and also to allow the AI to analyze your medical records. So on the left is the landing page that is on our website. So this is the landing page for XQers, and over here, I don't know if you guys can see my mouse circling this for patients X-Inform register as patients part. So this is where you will go if you want to create the account on your own. Once you click register as a patient, it will take you to an outside link to XQers platform, and you will fill out all the information it is asking. It takes less than 20 minutes to do it. It's a very simple process to create the account on your own. But now if you need help, a little bit of assistance to create the account, then you'll go to this green button here, which says X-Inform Patient Registration Assistance. This will take you to the interest form that we have over here on the right. It is the interest form for me to know that you are seeking assistance in getting help in setting up this account. You can see the form is very simple, just first name, last name, email address, and a few other information. I will get notified once you submit this form, and then I will reach out to you, and we'll find a good time to sit together on a phone call or Zoom to create this account for you. Okay. Yeah, so if you are interested in creating this account, so please don't hesitate to reach out to me. You have my email over there. You also have my phone number. If you feel like you don't want to submit an interest form, you can also just text me or just email me directly asking for assistance, and I will reach out to you to find a good time. My availability Monday to Friday, regular hours 9 to 5 p.m. But then I am also available Tuesday to Thursday, 6 to 9 p.m. This is mainly for working individuals who are also working 9 to 5 and are not able to find time within those hours. I am available to set up time during 6 to 9 to help you create this account.
Pacific Standard Time.
Yes, Pacific Standard Time.
Thank you, Shreya. So is the XQers platform entirely free for patients?
It is entirely free. There is no hidden cost. It is free for patients, yes.
Okay. And can pediatric patients have accounts on the X-Inform platform?
Yes, pediatric patients can have accounts on there. Their legal guardian have to sign a form, which you'll have to select an option when you are creating the account to sign that form. But yes, pediatric patients can have their own accounts.
Okay, so parents can register their
Yeah, parents can register on behalf of the child.
Okay.
And yeah, they'll just have to sign a form saying that it's not their account and their child's account.
And they're legally authorized as a representative.
Yes.
Okay, so that's great. A question came in, which I don't have the answer to that, but I did just text the person who will know. So I'm hoping that I get an answer really, really quick. And I think the question is, how many cancer cases does the XCures X-Inform platform have? Which means how many cancer cases, it has to be by disease state, right? Would they be comparing to your actual disease, your records, your pathology report, your genomic reports, all your tumor tissue information like IDH1, IDH2, all of that information. So we'll find out the answer to that question. You can contact Shreya at either her email or her phone number. You can text her or call her at that phone number and ask your question as well. So yeah, a lot of the questions that people typed in when they registered was they wanted to know about AI platforms related to identifying treatment options. And there's quite a few of AI platforms out there. And this just happens to be one of them that we're educating about today. So with that, you guys, I feel like we're coming to the end of today's programming. I want to thank our sponsors for our 2024 Know All Your Treatment Options, our presenting sponsors again, our KAYTO and Gamma Tile. And we are putting together our next Know All Your Treatment Options patient disease online webinar. So if there are any folks out there or companies that would like to come on board and sponsor this endeavor, please let us know. Thank you. We just got a great comment. It says, so good. Thank you so very much. Great content and presentations. Be well all. We also want to thank our in-kind sponsors for today's presentation, which are Servier, XCures, Fred Hutch Cancer Center, Zap Surgical, Novacure, and West Medical Center. And again, we do want to say a big, giant thank you to our sponsor for our 2024 National Hope Award, which is a patient disease education awareness and outreach initiative, and thank you Novacure for sponsoring that initiative with us. Thank you so much. Also, I want to thank all of the folks that submitted nominees for this particular initiative this year. And thank you to all of you who helped us make your videos and your informational videos. And thanks for helping us share your voice as a patient. And thank you for all the inspirational things you're doing today. And a big thank you to Patrick O'Donnell for our winning this year's recipient of our 2024 National Hope Award. Thank you, Patty. You are inspirational to all of us. Thanks so much. If there are no more questions or comments, I just want to make sure. It says, thank you. This gives hope, which is so important to this community. Yes, you're right. Hope is very, very important to this community. It's actually part of our mission. So thank you so much for sharing. Everyone have a great day. And remember, we're here. We're your resource and your advocate. Thank you so much. Bye-bye.